nicht diese Töne, sondern lasst uns angenehmere anstimmen und
wandering around and having fun with each other. Yeah, I know, but then I would shout. Sorry? For people online. Okay. I didn't know that. Okay, but I'm always shouting in these things. They say to me, take off the microphone of that man. So I said we are starting off health and social needs assessments in this session. I'm chairing Mark Bruinzels from the Netherlands. I have a background in population health management. I said we are touring the world, 3 continents, 5 different countries. Will be exciting. We have 5 presentations, max 50 minutes each. So I'm going to be a bit tough on time, or as you have to be as chair. We take questions after each presentation, and we see at the end whether we still have some time left for some other discussions. Then I'm going to introduce the first speaker to this session, and that's Amy Lynch. And Amy Lynch is from Ireland, and she's going to talk about evaluating financial competency and future planning as part of an integrated care comprehensive geriatric assessment. The floor is yours.
Sorry, so my name is Amy Lynch. I'm a specialist geriatric registrar in Galway University Hospital, working with the Galway Integrated Care Programme for Older Person Service. So I'm going to present today looking at evaluating financial competency and future planning as part of an integrated care comprehensive geriatric assessment. So I work at the moment in the Galway Integrated Care Service. So that comprises of 4 ECC-funded ICPOP teams in the west of Ireland. So the populations that are looked after by the service are very varied, from very urban populations to very rural populations. And this is a new and developing service in line with Sláinte Care. So it really strives to give the right care to the right patient in the right place. Who's seen by our service? So the patients that are referred would have a variety of different issues that we try solve for them. So patients with frailty, so that's a new or unexpected change in their mobility or functioning, patients that are having recurrent or unexplained falls, or very commonly a patient with a new or unexpected change in their cognitive function. These patients would tend to be over 75 years. They would have been assessed by the person referring them. They would have a high frailty index on the Rockwood Frailty Score, and would need input by 1 or 2 multidisciplinary team. What we mean by that is would need to be seen by, for example, the medical team and physiotherapist or occupational therapist, and the patient themselves is aware of the referral. These referral criteria aren't strict, and it's really on a needs and case-by-case basis. So the GICOP service will strive to see really whoever needs to be seen. Collaborative leadership is a real theme with GICOP, and there's a lot of in-service days where all of the members of the team will meet and try think together and see what the aim is. So this was the vision statement decided by all the team members. So it's empowering healthy ageing in your home and community. So again, that's really just tying in with Sláinte Care and looking for right care, right time, right place, and to keep older people well in their homes for as long as possible. Where are the patients seen? So they're seen, initially patients were seen in hospital outpatient clinics, which was quite prohibitive because they would need to travel a long distance, they'd have trouble with parking, and by the time they arrive at the appointment they might be quite distressed. So the move is to see patients in their own community, so either in satellite clinics or more frequently in their own home, which really gives a good insight into how they're living and the problems that they might be facing. So what do we do for the patients? We have a specialised geriatric comprehensive assessment pathway. So I suppose just for people who mightn't be involved in geriatric care, comprehensive geriatric assessment is an evidence-based pro forma to really assess all the facets of an older person's life, to look at how are they functioning at home, what medical conditions they may have, and to really strive to optimise things to keep them well, troubleshoot issues and avoid hospital admissions. So the comprehensive geriatric assessment looks at I said, functional capacity, are they falling? Is their cognition okay? Is their mood okay? Do they have polypharmacy? And then crucially for this project, looking at social supports, financial concerns, and the goals of care. So with this, the comprehensive assessment is carried out, a list of issues is highlighted, and along with that, a management plan to try to troubleshoot any issues. So these range from strict medical issues to social issues to issues with regards to finances. So for this project, just to highlight, the CGA would cover cognition, so any worries about their cognition, and also financial concerns, either now or financial concerns that we might predict become a problem in the future. So the background to this project is we kind of felt that probably the need for support in managing finances independently is an essential component of the CGA, and it's not something that's thought about very frequently, or certainly looking after older patients, maybe it's not at the forefront of your mind, but safeguarding of finances is really important, and something that's important to be thought about early in looking after older people, so that if they have a cognitive or a memory trouble that progresses, that we think about it early, plan for it, so that if things become a problem in the future, we kind of have the supports in place to deal with it then. So we sought to evaluate financial competency and preparedness in an older population attending our integrated care service in East and West Galway. So participants included in our service development project were new participants referred to the integrated care service between January and May with completed comprehensive pro formas. And then we kind of collated the data, and a retrospective analysis was conducted looking at the patient demographics, the ability to independently manage finances. So that was as per, there's kind of a section in the CGA asking them, were they subjectively happy with their finances, and also asking their caregivers, was there any concerns highlighted? And the level of dependency that the patients had for personal and instrumental activities of daily living. So personal ADLs, we call them, would be, can they dress themselves, or kind of do they need to help with those type of things? That would be measured by the Barthel index. And then instrumental ADLs was measured by the Lawton-Brady tool. So this is really useful and kind of quantifies a lot of the things that we do day to day that people may need increasing help in as they get older, or if their level of frailty increases. This very helpfully has a separate section looking at finances. So there's different grades of financial dependence in the Lawton-Brady. So the first grade, are they completely independent? Do they manage rent and bills and everything okay? So they really don't need very much input at this stage. So they would score a 1 for that. And then the second grade was that somebody would be able to manage day-to-day purchases, but maybe bigger purchases or more complex purchases might need a little bit of help with that. So they would also score a 1. And then if they have very significant trouble managing finances, they would score a 0. So as I said, just to bear in mind, the score of 1 has different grades to it. So our results. The median age of patients that we were seeing was 81. 56% of patients were female. 44% were married and living with a partner, and 33% were widowed. And I suppose who they're cohabitating with was really very significant with managing finances or any trouble that they might come across. And then very significantly, 33% had a documented mild cognitive impairment. So mild cognitive impairment would be defined as a little bit of memory trouble, or potentially a lower score on the scoring tools, but no functional impairment day to day. So their memory trouble doesn't really impact on their day-to-day activities. And then 53% had a documented diagnosis of dementia. So that's memory trouble that would impact on your day-to-day activities. And just to highlight again, the issues with memory is a real spectrum. And because somebody had a diagnosis of dementia documented, it just really means that we need to kind of practice person-centered care and meet them where they're at, and really make every aim to put things in place so that we can manage their finances with them, or that they will be able to get support to manage finances as far as possible. So looking at the functional and cognitive assessments of the Barthel score, looking at the PADLs, is 17 out of 20 was the average score, which is a reasonable level of dependence. The Lawton-Brady scale is 4, which would indicate that the patients would need a reasonable degree of help with their IADLs. And then the MoCA score, which is the cognitive scoring score, is 17 out of 30, which would keep with the patients having a diagnosis of mild cognitive impairment or dementia. So looking at the results from the financial capacity assessments, so we found that no patient had an advanced care directive. 90% didn't have an enduring power of attorney. So in Ireland, that's a legal setup that you nominate usually a trusted family member as your power of attorney. If you were to lose capacity at any stage, then it can be enacted, they can step in and help you manage your financial affairs and day-to-day affairs. But it does need to be set up with a solicitor, which is often a rate-limiting step. 41% didn't have a will, and then 80% of patients scored 1 in the financial section, which, as I showed before, shows either they're very independent or they're partially independent with their finances. 60% of patients collected their own pensions and felt that they were self-managing their finances. So to conclude, we found that although we highlighted that from our patient cohort there would be a high prevalence of cognitive impairment, so there's a likelihood that patients are going to have trouble managing their finances themselves, we found that very few had supports in place either now or in the future to help them safeguard their finances. We feel and kind of found that future planning for financial matters is a really key area of intervention and discussion for integrated care teams, and will be a really key sticking point to try and empower patients to live kind of how they'd like to live and manage their finances going forward. Limitations with regards to financial planning in older people in an integrated care setting. So there's no medical social worker attached to either of the integrated care teams, which I suppose is a big problem. So that's going to be part of the workforce planning going forward. So the primary care social worker is quite heavily relied on. As I said, enduring power of attorneys are very useful, and they really can help streamline things in the future if the person were to lose capacity. So they're very important, but the legal pursuit of an EPOA can be very financially onerous on families and quite difficult for them to attain. And then I suppose another issue at the moment is that there's been a change in legislation in the south of Ireland. So there's been a legislation called the Assisted Decision Making Act, which has been brought in to try and protect vulnerable patients and really optimise them to try have them be supported in their decision making. But so it's not technically related to EPOA, but the spectrum of EPOA has become a little bit more grey, and I think solicitors, some of them are getting a little bit more hesitant to bring them in. So that's a problem that we're going to have to deal with, and probably will become more prevalent going forward. So just to emphasise again that supported decision making is really essential to uphold the right of older people to make choices on their welfare, property and affairs, and becomes more important as potentially their cognition declines. CGA and integrated care provides a really important opportunity for assessment and intervention with this, and we should really consider financial planning as part of the CGA to empower older patients to be continually independent with their finances and start this when they're well. So since this project, we have further changed our CGA to capture financial planning and inquire about it more. As I said, and we've brought in education for our staff members as well. As I said, the landscape with regards to the Assisted Decision Making Act has just become a little bit more complicated and will continue to be ironed out. I think it was brought in last year, so it is new, and we're all just learning how to interact with it. And just to re-emphasise as well that the Galway Integrated Care members are going to aim to further promote conversations with regards to financial and future care planning going forward. So I'd like to thank especially Maria Costello and Michelle Canavan, who run the Galway Integrated Care Service, for the help with this presentation. Thank you.
Thank you very much, Amy. Room for questions, suggestions, remarks. Please. Maybe you can say who you are. And then
Thank you so much for that. I was so interested. My name is Sarah Murphy, and I'm doing a PhD on three income sites around the country, and they seem to vary in terms of social work. And I'm just when you said there's no medical social worker, was there any social worker on the team?
Not at the moment.
Okay, but
no.
that's the plan. And then I just had a second question I wanted to tag on as well. Was there resistance? Like, did you encounter any resistance just about the idea of clinicians taking on responsibility, or not even, but just looking particularly at financial assessment as part of a medical assessment, or did that go smoothly? Because I think it's brilliant that you did that.
So the CGA wouldn't necessarily always be carried out by the doctor. So the GICOP is really a team. Okay. So the advanced nurse practitioners, occupational therapists and doctors, one person would take charge and carry out the assessment, and then the patient will be discussed. So I suppose it's in the context of geriatric medicine, so kind of the holistic care would be our focus. So no, we didn't come across any but as I said, it wouldn't necessarily always be the doctor carrying out the CGA. It would often be another team member. Everyone's kind of, it's equal standing. It's a real collaborative team.
That's great. Thank you.
other remarks?
Hi, I'm Leanne Bruce. I'm from Scotland, part of an allium. It's really interesting that you're using multiple people to complete the geriatric assessment. Does that include reaching out to any formal carers or community supports in relation to the person's situation at home, or is it just within that team?
So the team would be very much so have an integrated approach. So kind of people who are referred to the integrated care service would need usually two modes of input. So they might have a medical problem, and they might, so say somebody who's falling would need a medical assessment looking at their medications to see why they're falling, and then also would need a physio assessment. They would very frequently need an OT assessment, and seeing them in their house is very useful because you get a really good idea of how patients are managing. So people who refer to the integrated care service are seen by either, as I said, an AMP, then discussed as the team with the clinician, and then after that, an intervention plan or a management plan is made, and then at that stage, if kind of community supports will be utilised, and then very frequently, say, formal carers or public health nurses would have been the one referring them in. So it's a real team effort, and then certainly the information from the formal carers in the community is very useful.
Thank you.
Final question?
Thank you for that, Amy. It's a really important project considering how disgraceful it can be for families financially if the person isn't followed up. Well, they're not identifying the people that had dementia or mild cognitive impairment and they didn't have a will or no power of attorney. I wonder in terms of, they've participated and we have the figures, but in terms of follow-up and sort of like duty of care, since these patients were flagged, what happens?
So I suppose certainly in terms of the will, I was very surprised at the low numbers of people that would have a will completed. Promoting it really is the main thing that we're trying to do. So talking to patients and their families about the importance of having a will in place, especially writing the will when you're well, and then ideally getting an EPOA in place. As I said, that can be difficult, and then we're moving more towards having advanced care plans in place. So it's the response to this is really trying to promote it, trying to facilitate people to carry them out as far as possible and provide support moving forward.
Thank you.
Okay, thank you very much, Amy. Then we continue with the next presentation we fly all the way to Singapore, and Taufik is going to tell us more about their unified needs assessment.
Hi, thanks everyone. So I'm a medical resident in Singapore doing preventive medicine, so I'll be talking to you about our unified needs assessment, a bit about the rationale for why we wanted to develop it, and then a bit on how we developed it and how we plan to implement it. Okay, so I'm going to start with a bit of context. I think a bit of context is important to know why we're doing this project. So I'm part of Yishun Health. Yishun Health is an organization within the National Healthcare Group, which you can see in the center. We really take care of the population within the central part of Singapore. And Yishun Health is really at the very top. We take care of Yishun Zone. We have 320,000 residents that we take care of, and we are an integrated care organization that was formed in 2017 to take care of these residents. And we work with all the stakeholders in the community to take care of our residents. We also manage a 800-bed acute hospital and a 430-bed community hospital where we provide intermediate care for patients. And we also have specialty medical centers. We also help support some of the primary care clinics and so on. So as part of our efforts to integrate care across our whole system, because we have so many facilities, we have so many responsibilities, we thought having a good needs assessment tool was important because we wanted to be able to do good needs assessments both at the individual level and also at the community level for resource allocation and so on. So I'm going to start with what is a needs assessment in my definition. So they are a systematic process for analyzing and describing unmet needs in a defined population. And through discovering these needs, the main goal is that we can allocate appropriate resources and we can design an appropriate care plan for our patients. And needs assessments are done at both the individual and population level, as I mentioned earlier, but we find there are issues with how these are done across Singapore and even in other health systems across the world. So for individual needs assessments, I think the inherent problem is that a lot of them are very much focused on diseases. They are very specialty specific, so you have different specialties having their own assessments. You have different institutions having their own assessments for various reasons, and it's very fragmented. You have multiple different assessments for different reasons. Some of the questions are duplicated and so on, so there's a lack of integration there. And when we talk about population needs assessments, none of these population needs assessments, very rarely do they integrate with the individual assessments themselves. And these population assessments often focus on specific areas. So for example, they'll focus on mental health, there'll be a mental health survey, or be a chronic disease survey for the population and so on. And you have residents receiving multiple surveys for multiple reasons, and there's that lack of integration for population assessments as well. So in Yishun Zone, we really envision a unified process for assessment, and it starts with a single, comprehensive, and person-centered tool that we think should be applicable at the individual level, and that will be applicable to all residents across all care settings. And that is what we envision and what we wanted to develop. And because it's unified, it will enable us to aggregate the data at a population level. And as population health managers, because we also run a health system and we take care of our residents, we can then direct our resources to meet our population's needs. And on top of that, when we have the data, we can then use that data to segment a population and more efficiently decide how to distribute resources and allocate resources to optimize health for our patients, and that improves our individual residents' health. So with this in mind, we had to think about, okay, how are we going to develop a tool that can fulfill these lofty ideals and challenges? So we started with a methodology that began with a literature review. So we wanted to look through the literature to find validated tools that were, as much as possible, person-centered as our starting point. Then we adapted these tools to be more locally contextualized. We also wanted them to be as comprehensive as possible, so they can cover all bases and can really work towards optimizing health and well-being for patients. And at the same time, we also applied systemic design principles. We had to think about how this tool that we developed really fit our use case as a population health manager and as someone who also runs healthcare facilities. And finally, we also had to engage stakeholders. So our stakeholders within our health system, including people who run operations, those that do the clinicians, even those that do clinical informatics. So these were all important stakeholders we had to engage multiple times with regards to implementation and design. So I'm just going to briefly talk about our literature review. So we looked through the literature and we narrowed down a few tools. This is just 4 of them that we narrowed down and we thought were person-centered. But we really focused on the Omaha system. So the Omaha system was actually a framework that was developed in the 1970s in the US, in Nebraska, and was used in the field of nursing. And the main strength of the Omaha system is that it has a standardized way for documenting and communicating a patient's status or a need status. So that's what we thought was the strength of the system. And it's a really flexible tool. It's very comprehensive. It can be used in all care settings. It has a very standardized taxonomy and needs that I'll show you in the next slide. And it also had the ability to measure knowledge and behavior of a resident. So we thought these were all very useful features in a comprehensive tool. And we also appreciated that other tools also had self-assessment versions, so we thought we could use that quality in our adapted tool as well. So I'm just going to show you what the Omaha tool looks like. So this is the problem classification scheme that the Omaha system uses. It has 4 domains, and it has 42 needs categories, or these are 42 different categories of problems. But we felt the problem in applying the Omaha system as it is to our system and as population health managers were these 3. Firstly, it focused a lot on pathogenesis, so there was a very negative framing of health, and we wanted a more positive framing of health. Next, the tool was not locally contextualized, so we felt there were some categories that were missing that we could add in to be more locally focused. And lastly, we felt it was not comprehensive in a few ways. So firstly, it didn't look at children, so there are no needs categories specific to children, like child development and so on. Nothing that focuses, a little bit of focus on preventive health, but we thought there could be more focus on preventive health. And also we thought there could be a better conceptualization of health and well-being beyond just disease-focused way of looking at health. So we wanted a framework that could really expand and broaden our understanding of health. And we used Maslow's hierarchy. So I think a lot of us have heard of Maslow's hierarchy, but we wanted to use it to broaden and conceptualize what health should be for every resident. So we took these 4 main categories, and we envisioned that biological means or biological needs are the most fundamental for human survival, so they would be at the bottom. And you need to achieve those before you can achieve higher tiers of needs. And that every resident wants to achieve esteem and self-actualization as the final goal. So with this framework in mind, we built on the Omaha system, and we developed a total of 47 categories together with our stakeholders and in multiple engagements. And this is what the framework looks like. So we took a lot of the categories from the Omaha, we changed them up, we changed the wording, and we used more neutral terminology because we wanted to align with salutogenesis. We also used terms that were a bit easier to understand from the local context. We also ensured that all the categories were mutually exclusive, so there's no overlaps in them. We wanted to ensure they were as comprehensive as possible or totally exhaustive of all the needs that a resident would have in our population, and be able to achieve self-esteem and actualization. That's why you see categories like confidence, improving myself, and these were not categories in the Omaha system. And importantly, we also wanted to think about children, so we added in development at the bottom left, and we also added in a few categories related to prevention. So you can see screening and vaccination in there as well. And we also, this is how we developed the problem classification scheme for our tool. But we needed to think about now how we're going to actually collect data from our residents. And so we started to think about that process and that path we were going to use. And together with our stakeholders, we narrowed down to 5 steps that we would have in this process. So the first step was to identify signs and symptoms or challenges. So it sounds very disease-focused, but this is how the Omaha system calls these questions within each problem category. So even within social care needs categories like things like confidence or things like mental health, there are signs and symptoms, but they are not disease-focused questions. So just to clarify that. And challenges were how these questions were phrased if you were to do this as a self-assessment. And this self-assessment version was adapted from another program that was developed in the US called My Strengths, My Health. So it's also a validated tool that we adapted for the self-assessment. And the goal of this first step was to identify actual or potential needs in our residents. In step 2, we also wanted to grade how severe the needs were in the patients, and we can use that to kind of prioritize our care plans for the residents. In step 3, we also wanted to do a behavior and knowledge rating, and the idea was that we could guide residents to close their own gaps in their own ways by improving their knowledge and by engaging in behavior change. Step 4 was the asset discovery tool, and the idea was that if we could document resident assets, we can then incorporate them into the care plan, and this is the basis for having a strength-based framework and being able to use the patient's own assets to improve their care. And step 5, we wanted to also capture anticipatory concerns. So beyond just actual and potential needs, we wanted residents to think about any anticipatory concerns they could have. For example, middle-aged woman who's thinking about pregnancy, she may have concerns, she may have questions to ask. So we wanted to capture all that and be as comprehensive as possible in the process. So in discussion with stakeholders, we put these 5 steps together in this order. The idea was that it will help practitioners differentiate the types of needs. So you can see we differentiate between unmet needs and needs that are considered met. And we can also, through this process, identify anticipatory concerns and needs. And if there are unmet needs, we do grade the severity of the need. And the idea, again, is for care plan prioritization. And at the same time, we assess the behavior and knowledge of the resident, so we know how to improve on their care. And these steps would be carried out for every one of those 47 categories. So it seems like a very big task for the individual to do an individual assessment. But maybe in the next few slides, I'll clarify how we wanted to make it into a very efficient process. So as I mentioned, now that we had the tool, we need to think about implementation and how we can make it efficient to be completed. So I think the most important prerequisite and criteria in order to get this implemented was that we needed someone accountable, a single individual who could be accountable for the data that they're going to collect, accountable for ensuring that the resident has an assessment. And we decided that this would be a physician, and we termed this person the primary coordinating doctor. This primary coordinating doctor would not be able to complete the entire assessment for every individual. It'll be too much work to do. So the idea is that we could get the assessment completed by multiple different stakeholders within the health system. So you can have your social workers, your community health teams, your primary care doctors, or even specialists contribute to different parts of the assessments depending on what is relevant to them in their care. And all of this information goes to the primary care doctor. But at the same time, we also mentioned we wanted to have self-assessments. So on the other side, we'll get residents to do their own assessments. The caregivers could do it for the residents if the residents could do it themselves. Or we could even have community workers or community health teams do it for the residents. And we envision that these self-assessments would make up the bulk of the information for the otherwise very healthy residents in our population. So the role of the primary coordinating doctor is really to bring all this information together, deconflict the contradictory information, and also the final the information that they approve as the final assessment is the official representation of the patient. And this will be facilitated by a transactional system, which is the National Electronic Health Record that we have in Singapore, which is EPIC. And the idea is that this system will allow for data transfer seamlessly and at the same time ensure data security. So the primary coordinating doctor's role is really to ensure the needs assessment for an individual is collected accurately and that they're responsible for the data that's collected for the individual. But this data would be stored on this electronic system, and any provider could access this information. So you could be a physiotherapist who's seeing the patient, and you want to know what the patient's need status is, so you can address these needs accordingly. And at the same time, as population health managers and people who run a health system, we also want to be able to take this data, and since it's unified, we can aggregate this data and we can use this data to decide on how we're going to allocate resources to our population, also how we're going to develop segmentation models to decide how to efficiently allocate resources to them as well, different segments of the population. So last slide. In conclusion, we think a comprehensive and person-centered needs assessment is the future for value-based health systems like ourselves in Yishun Health. And we think having a unified and standardized tool for needs assessments really enables the work of population health managers, and at the same time will also support our doctors and clinicians and healthcare workers on the ground. So this unification of assessments for individuals and populations will help us achieve integrated and effective patient care and also effective population health management. So some of the features we think are very interesting for our tool that we've developed so far is that we want to have both provider and provider assessments and self-assessments contribute to this needs assessment for the patient, because we think the self-assessment from the patient also provides their perspective and their inputs on their unmet needs. And at the same time, also having a national electronic health record, which we are working towards in Singapore, is very helpful for making this a reality. But of course, we still need to do a bit more work to ensure it can collect the needs data that we want it to collect. Some future work that we still need to work on is, of course, I think getting healthcare workers on board is very challenging. I've had to engage with lots of different healthcare workers that were pushing back. And I think getting them on board, one way to do that is to find a way to map all their existing scoring tools into our needs assessment. And at the same time, the other thing we are thinking about is how we could use this needs assessment as a way to enable healthcare financing through capitation. So that's things we're thinking about for the future. So I will stop here, and we can, for Q&A, and if you need to connect with me, you'd like to connect with me, you can scan the QR code. Okay, thanks.
Thank you very much, Dr. It was a nice presentation. You have a question. You can't wait. 1, 2. Okay, maybe you can.
Thank you so much. I'm Pauline Pariser. I'm with the University Health Network in Toronto, Canada. I have 2 questions. The first one is, what is the time frame that people have to collect this information? And is there consideration of administering the needs assessment more than once? Like at what, how do you figure out the age categories? I just was interested in that. And the second question is, how do you design the tool so that it meets the needs of people who are structurally marginalized, who have poor educational levels?
Okay, so for the first question, so I guess this is one piece of a very big puzzle in our health system. We have so many ongoing projects. And right now we're thinking about doing it at a yearly interval, so annual assessments. But of course, I think this is still in flux. We're still discussing with our stakeholders whether this is reasonable, whether it's possible to do it, and whether if we don't even have a completed assessment at the end of the year, what's going to look like the subsequent year. So right now we're thinking annual, but this may change in the future. And your second question was about marginalized populations. So I think what you pointed out was also along those lines was that we haven't really engaged people on the ground, haven't engaged our residents, and that's another step we need to take moving forward. Currently, this is really still in the early stages of development. So these are some of these ideas are something we're thinking about moving forward, because we're going to have to keep improving on this tool. And the fact that we're doing self-assessments means we probably need validation from the residents on the ground for them to understand the questions that we're asking them. So that's definitely a step we've got to take. And I think speaking to the marginalized populations is very important. In Singapore, we have a lot of minority groups, including the racial groups and religious groups. So that's also a very important consideration for us. Yeah.
Thank you so much.
Hi, thank you for your presentation. My name is Anne van den Bulk from Maastricht University, the Netherlands. I'm an assistant professor over there. And I was wondering, as I have experience with collecting data for patient classification in a case mix system, we explicitly didn't use Omaha's system as we had some trouble with the standardization of the data. And that might be because it's totally different in the Netherlands, as we do not have one system overall. Home care providers, healthcare providers, actually nowhere. But I was wondering, did you consider how you would dig a bit more into the standardization of those different aspects of the Omaha system? As I can imagine that with all those different kinds of professionals, that might be quite a challenge.
Yep, so I guess when we were engaging some of the healthcare professionals, some of them saw it as, okay, this needs assessment is going to remove all my other assessments, but we don't want it to be that way. The healthcare professionals should still be able to do their own specialized assessments or specialized history taking. This is not to replace the history taking or physical examination anyway, but this is to provide the health system and the primary coordinating doctor a comprehensive understanding of the patient. With regards to why we chose Omaha, we just thought it was the best tool that we could use as a starting point. I think compared to the other tools out there, we still felt it was quite comprehensive. But that's why we still did that adaptation after that. And we still used Marcus Lowe's as a framework to do the adaptation, because we thought we could still build on that comprehensiveness. And that's why we integrated all these locally contextualized categories in there as well. Yeah, I hope that answers.
Thank you.
Okay, thank you very much. We continue to our next presentation. We go back to Europe again, so we go to Finland, and we go to Timo Sinervo, and Timo is going to tell us something about the assessment of service integration in Finland, but he's going to use the Scirocco tool. Timo, the floor is yours.
Okay, thank you. It's here. Yes, I'm coming from Finnish Institute for Health and Welfare, which is THL, and we have tried to assess our integration using this Scirocco tool. And we are not trying to invent it again. We are just trying to find out is it suitable or not to analyze our system. And background to this is that we had very large system reform in our health and social services. We might say we are fully integrated, at least at organizational and budget level. We have 22 plus 1 county which have responsibility for arranging all health and social services and rescue services. And the money is in these counties also. So we are not having any different sources for where this money is coming. Except that we are having occupational healthcare system, which is totally separate system for employed people, which is one of our main problems now. Anyway, we had 150 municipalities who had responsibility earlier, now 22 plus 1. It started at 2023, but actually 9 regions started this earlier in voluntary basis. Also, these counties are providing the services by themselves mostly, but there are some areas where we can outsource services also to some extent, not all services, because we need the counties to have also their own services. For example, assisted living services for older people, mental health, majority of these services are outsourced nowadays. Some also on primary care. We have actually very long tradition on having integration. Our health centers have always been from 70s multi-professional organizations, which is our primary care. But still we have also several problems at the floor level. Organizational integration doesn't mean that everything goes smoothly at the patient and doctor nurse collaboration. And in practice, integration at the floor level, it varies very heavily in between counties and in municipalities also. And now, as with integration was one of the driver of our organizational change, we would need to also measure it. But there is a problem that there is a lack of measurement instruments because most of these instruments are disease specific and this kind of overall measures are very rare. So this is our group. We had researchers from THL and also University of Turku and also Center for Client and Patient Safety. I'm not going to talk much about these dimensions, but we just like these dimensions because it's not one thing only, it's several dimensions that have to be realized if a real care integration can happen. So we translated this Scirocco tool and also modified it to our Finnish health and social system, which was actually not so easy because our system is quite different. For example, because our social services are also in the same organization. And we had 4 well-being service counties and tried to gather information from them, suitability of this instrument in county level, in development, and also comparison between counties. And as this tool is mostly used as a development instrument, for example, top management team is sitting and discussing of care integration, they can use this tool. But we used it as a survey tool, and it's a bit exceptional looking survey tool. So we tried to find out, is it working really? We also made a review of our measurement tools, but were not many comprehensive tools actually. Data is quite small for quantitative study. We only had top management, middle management, frontline managers, and some frontline workers too. We had only 135 answers because this was kind of a pilot study. Yeah. Now, something about these results is that there is quite strong differences between professional groups. With darkest area, which is going to number 4 and number 3, is top management, and the inner circle, that's frontline workers who think much more negatively on what's the status of a maturity of a care integration in their county. So top management thinks much more positively about these things. And it may be quite natural because care integration is at their work table. They are doing it and planning it, and they think the plans are now ready, but actually the implementation is just starting. Here, 1 means that nothing has happened, 0 means that nothing has happened, 1 means that some plans and something has been recognized, but something has to be done, and number 5 would be full maturity of integration. Largest differences are in readiness to change, organizational structure, and in some counties this organizational structure there was huge differences between top management and frontline workers. Also digital infrastructure, because these counties have formed from 10 to 20 municipalities which all had their own patient records, meaning that the counties are just planning to get their own unified patient and record for health and social services. About counties, these numbers B and C, they are those counties which were formed earlier than the other ones in voluntary basis, so they had also some years to develop their integration beforehand. And they are with, is there a point or not? Yeah. These two are these counties which have started earlier. And we think this is quite a positive thing for this measurement also, that there is variation, and this variation is logical. Because in these other counties, they have been just formed in beginning of 2023. So they had only started their planning of everything. Okay, what about suitability? We also collected some information from the counties and from all these questions. And the counties thought that it was a suitable tool, and it gave suitable and useful information for them. For example, top management recognized it very clearly that we have different views from frontline managers and frontline workers. And we thought that follow-up is needed, and actually at least 2 of these counties are continuing with in this spring. And we were happy that there were differences between counties that might have some kind of implication that this tool is a reliable measure. There were actually also some difficult parts. For example, evaluation and funding. It was quite difficult to answer for the frontline workers because they didn't really know about evaluation and funding. Is it good or bad? They knew that their salary doesn't change even if they do anything, but other things they didn't know. So we found out that we need some kind of further development, at least if we are using this as a survey instrument. Because in this instrument, one question actually had several questions inside. And this is quite okay if you are using it as a developmental tool. But for a survey instrument, it's difficult to answer at the same time for 3 questions. So now we are trying to separate these questions to 3, maybe 4 different questions. In the left-hand side, you can see what was the question originally, and you can see it's quite long expression of what does, for example, readiness to change mean and what can be evaluated. And as I said, it's pretty good tool for if you are sitting in the table and thinking about your organization, you have these questions to help you think what is readiness to change. But for the survey tool, we are now trying to convert it to different questions, meaning that this readiness to change would have, for example, 3 different questions. And don't read the wordings, it's just scratched by hand. Now it's not the final version. This is what we are trying to do now, and let's see what are the results. And here's something we have been doing in Finland. There's something about Finnish system and also with original Sirocco references. Thank you.
Thank you. Questions, thoughts, reactions, ideas, how we can develop?
Thank you very much for your presentation. The Sirocco tool is quite dear to our heart in Scotland because we were heavily involved in some of the early piloting. I'm just wondering if some of your results might have looked different if you had citizens or more public partners responding to your survey rather than just managers and professionals.
About who was answering to this, it was only the public side, because this was kind of a pilot. And in next phase, we might also take some private service providers, because of course we know that there may be a gap between the public services and private services, because we have a different kind of compensation for the services and integration. I would say that mostly it's not taken into account in this compensation system. And yes, I was a bit afraid, what are you asking about Sirocco, as I saw you in the speaker list. Yeah.
Thank you, Timo. Others? I have a small question. You touched upon the different perspectives on integration by showing the maturity index for different groups. Do you think it's feasible to have one instrument that is applicable for all the different groups, like frontline workers, higher management, maybe even patients? And is it feasible, or should we forget that?
Yeah, you are quite right. But let's take, for example, our health centers, which may be 10 health centers in one county. In one health center, which may be at very good level. But it's also possible that we are not only asking from top managers and middle managers, but we are taking some areas, for example, health centers as a topic, or diabetes, or something else. So this is just beginning.
Under discussion. Thank you very much for your presentation, for your contribution. We head to the other side of the ocean. We go to Canada, and for people who came from Matthew Myers, that's a disappointment, but we are very lucky that Jacoby Elliott is here. Matthew had to be in 2 places at the same time, which is not possible, still not possible. But you are going to tell us about your experiences about a holistic needs tool.
Yes, great, thank you. So I'm Jacoby Elliott from Ontario, Canada, and I'll be presenting some preliminary work on developing a holistic needs screener. I'm presenting on behalf of a large group of people, and my colleague, Dr. Sarah Jarmain, is here as well. So before we describe the development process, we wanted to start by grounding this work in population health management and the framework here on the screen. To do population health management well, you really need to understand your entire population and segment the population based on risk and need. Unfortunately, we don't have a really good process in Ontario to understand our full attributed population. So this has been really the reason behind this work. How can we build a tool to help us understand the full population that we should be caring for in our community? So we set out to develop a short screening tool that would help us identify those who need services in our region. We wanted a really short tool with high-level questions spanning different domains of health and wellness. We wanted the tool to be self-reported to enable people to self-identify their needs. And we wanted a tool that led to next steps, such as suggestions or referrals to other community services as appropriate. Through interviews and co-design sessions with patients, caregivers, and providers, we heard that people wanted a quick tool that could support identification of a need and also promote early diagnosis. We also heard the need for more information and education about available resources in the community. So again, really wanted a tool that had questions that identified the need and then defined actions based on the results from the tool. Additionally, in Ontario and in Canada, we have a large population of patients who don't have access to primary care. So we wanted a tool that could help us assess for health changes in our community, especially for those individuals who are unattached to a primary care physician. So overall, we had about 80 providers, patients, and caregivers contributing to the early development of the tool and the associated care pathways. Through co-design, we landed on a definition of health and have based the screening tool on domains off of this definition by the National Collaborating Center for Determinants of Health. So they define whole health as the physical, spiritual, mental, emotional, environmental, social, cultural, and economic wellness of the individual, family, and community. And there was a lot of work that went into this with our co-design sessions and a lot of debate around the different domains and what each domain means, and a lot of complexity around the difference between emotional and mental. So it took a lot of time to sort through the definitions of the domains. We also did a little bit of a literature review on existing tools, and we didn't find one single tool that really matched these 8 domains. So that really led us to thinking about developing our own tool and what that looked like. We definitely didn't want to duplicate what was out there, but we just didn't have any luck finding a really short screening tool that matched what we were looking for. So as we started building the screening tool, we developed a number of functional requirements in partnership with patients, caregivers, and providers. So again, the tool needed to trigger actions and care pathways based on the screening results. The tool should be able to monitor health and health changes. It needed to be quick and easy to administer with fewer than 10 questions. And we wanted it to be inclusive of those domains that we landed on. We wanted it to complement more in-depth assessment and not duplicate the existing tools that already exist in our healthcare system. So we ended up developing a partnership with IJIC, a collaborative network of researchers, clinicians in over 35 different countries around the world. So IJIC has developed a number of healthcare instruments designed to be used across the healthcare system. But currently, many of those tools are more detailed assessments. So IJIC was really interested in partnering with us to develop this holistic needs screener that would identify appropriate individuals who would then go on to complete more in-depth IJIC assessments. And we believe this tool will be applicable to communities outside of Ontario, and leveraging the IJIC network, we can test this tool in other countries as well. So IJIC tools are validated and reliable tools, and they have a whole bank of questions already validated. So we were able to align IJIC questions to the 8 domains that we were interested in. So this is just an example here on the screen of some of the questions that we could have selected for this physical health domain. So how would you rate your physical health? Do you get help with basic activities? Or in the last 3 days, how often have you had pain? So while we're in the development testing phase of our screener, we're having a few different questions for each domain, but our hope is that we'll narrow it down to just 1 or 2 questions per 8 domain. So we wanted to highlight a little bit of a case example of how we envision the tool in practice. So let's take George, a 62-year-old male who recently moved to London, Ontario, Canada. He is generally healthy, and he completes the screener. Maybe it was emailed to him. He's new to the community, so he does not have access to primary care right now. He identifies he's lonely and feels down. So what do we need to do about this? Through the information gathered in this screening tool, he can then be contacted by a community partner who can provide him with options for self-management and education. At this point, no further actions are taken, but we can check back in 6 to 8 weeks and see how he's doing with those self-management and education suggestions. We can take this same example, but let's say George actually has a number of health concerns and identifies that he struggles to get out of his apartment. So in this scenario, with our screening tool, we would actually, and based on his results, we would actually connect him to a community navigator who could provide, rather than providing the education and self-management options, he would get a full comprehensive assessment and would also be referred to appropriate services. So he'd be connected to services for support for his healthcare needs. So these are just 2 examples of how the tool could be utilized based on the individual's needs. And of course, since we know he's new to the community and isn't currently connected to primary care, we would get him on our large roster to be connected to primary care. So again, we envision the resulting tool will triage individuals based on level of risk and connect them to the most appropriate services, depending on how they answer the questions. So those at low risk would have more of the self-management education options, and those at high risk would be referred for more comprehensive assessment, and likely using those more in-depth IJIC comprehensive assessment tools that are already in place in our system. So again, the beautiful thing about leveraging IJIC is it's already a common assessment used across many of our healthcare sectors. We just really wanted to build that screening aspect. So currently we have identified the IJIC questions based on the domains, and we're now in the process of testing this tool and the associated care pathways that we've co-developed with patients, caregivers, and providers. We'll test the tool with a sample size of about 300 individuals to check on our algorithm and see how the pathways worked out before rolling this out to our full attributed population. We will continue to engage our patients, caregivers, and providers in this work as we learn about the tool and how it performs in practice. So we look forward to sharing the results at next conference, IFIC conference. And I'll leave it there and invite Sarah to come up and help answer some questions.
Thank you, Jacoby. Very interesting. Yep, I already see one question.
Thank you. Very interesting plan and presentation. Monica Perez-Yales from University of Colorado, United States. We are trying to do something very similar. My question is, how do you envision including the 8 domains, very interesting, whole person care, with a fast tool with just 10 questions? We struggle with that, the usability and pragmatic tool versus the 8 domains are amazing. How are you handling that, planning?
Yeah, I can start. It's a great question, and I think something we struggled with when we did the literature review to look at existing tools. We just couldn't find something that touched on the 8 domains. And again, I think that's why Intereye was really interested in this partnership, because although they have a couple of screening tools, their screening tools are very specific to a specific condition or category, so a mental health screening tool, for example. So that's our challenge right now. Our tool sits at about 16 questions. Because we do have a few questions per domain, but through our testing phase, we'll see which question is performing better to trigger need, and see if we can get it down to hopefully 10, but not sure if you have another answer.
Maybe just to add, I think we had a lot of discussion about the difference between screening and assessment. And so screening is really to identify from a patient's perspective, or sometimes family caregiver's perspective, is there an issue, concern, or a need that then we have to ask more questions about. And so it's really having that opportunity. You know, many people will say, you know, most of things I'm great, but I just got notice that my apartment building is being sold, and I'm really concerned about what's going to happen if I don't have a place I can afford, right? So it's separating those two out. It's also thinking about where along a patient journey are the appropriate places to use a holistic needs screen versus where are those places that right from off the start we're going to want to do more of an in-depth assessment.
Others? Oh, that's in the back. No, you need the mic because they can't hear you.
Maxine Radcliffe, work in various things in Ireland, in the Republic. Curious to know if you are interested in other partners collaborating to operationalise something like this in terms of the research, because what you're describing is the kind of thing I need to stand up yesterday in migrant and homeless services, and I'd love to collaborate with you on a
Yes, absolutely. And again, I think that's the beautiful thing about the network that Intereye has is we can connect with many countries around the world and collaborate. So let's connect after.
Others? Yep.
Can I ask you, is there a plan to link the high-risk people with prioritising them to have a GP? Right? It sounds concerning that there would be a 62-year-old with diabetes with no primary health care doctor, or might that be an integrative thing that might happen?
So sorry, let me make sure, because it's hard to hear. So your question was for the high-risk individuals. What are we going to do because they don't have a primary care provider, and what's the pathway for them? If I got it? Okay. So lots of conversations happening right now. We're just in our evolution implementing primary care networks, and this is one of the major areas of accountability that's envisioned for primary care networks. So we're having discussions around different models for unattached patients. Some communities have set up pop-up health clinics. Others are really working to say, how do we pull together teams that may work in different ways to be able to create some capacity to manage that. One of the examples in our community right now is the Health and Homelessness Whole of Community initiative, and as part of that there's been some government funding to specifically target some of those highest need individuals, and it's really a network of different organizations coming together to say, how do we meet this need in a different way?
I think I'll just add, just based on your presentation, and I have an interest in geriatrics as well, I think, We know that for older adults need to be referred for a more comprehensive geriatric assessment, and those without primary care are not getting that referral because no one's signing off on that referral. So having mechanisms like this tool and then someone who can take accountability to make that referral, and then they can get to the right place to get the assessment they need at the right time.
Other questions? Final one, yes?
Thank you. So my question is, what is the eligibility of people who will participate in the screening? So it's everyone like they will do the screening like voluntary, or you have some target population? Thank you.
Yeah, great question. So I should have mentioned that the tool is for those 18 years of age and older. And in our testing phase, targeting a few community partners that can help us with a variety of people in our community. So though newcomers is a large population in our community, those experiencing homelessness, and then we're also partnering with a primary care physician who has a vast population that he serves in his roster. So for our testing phase, really looking at across diversity of the community.
Yep, and I think once we're through that and have implemented the tool, the idea is that everyone in our attributed population, which is a combination of geography plus who is rostered to particular primary care providers, would have the tool. And as new people come in and they're interacting with the system, if they haven't had it yet, that would be the opportunity to do that. But that's where it ties into that attributed population registry to be able to hold that information.
Thank you very much. So a nice example of a screening tool instead of an assessment tool. So I think we need both of them. And we fly back then from Canada to Scotland. We're going to Anne Henry, and she's going to tell us a little bit more about the understanding the value of a compassionate community. Anne, floor is yours.
Thanks very much, Mark. And I was reflecting that all of the other wonderful presentations have all been about assessment and analysis, so I'm going to fast track you to the review part of that commissioning cycle. And I'm going to talk about work that's really been led by Alison Bunce, who can't join us today, but hopefully she'll be watching live on stream. And it's been led by Compassionate Inverclyde, which has shared its story a bit at the IFIC conferences before. It was established in 2017 as the first compassionate community in Scotland. Last year we heard about the wonderful Caring Neighbourhoods development in Flanders, and I think yesterday they were having their evaluation conference. A community where everyone recognises we all have a role to play in supporting each other at times of crisis, end of life or loss, and it's about ordinary people helping ordinary people. Its purpose and its values of kindness, helpfulness, neighbourliness were co-designed, co-developed through conversations. So very much reflecting what we talked about this morning in the plenary, about having those good conversations with local people, local citizens about what matters. It's very much aligned with Scotland's national values, although it's a community of about 80,000 citizens. It's aligned with the country level values. We are a society that treats all our people with kindness, dignity and compassion. That's the values we aspire to, respecting the rule of law and operating in an open and transparent way. It's a collaboration. It's not a single organisation. Compassionate Inverclyde had multiple partners. And again, I think what we heard this morning from New Local and from colleagues in Northern Ireland about creating productive partnerships partnerships of equals. So although the local government and the health and social care partnership and academic organisations were around the table, so too were the police, the hospice, and other third sector organisations like Macmillan, the Health and Social Care Alliance colleagues, and Your Voice, a local mental health advocacy organisation. So it really was a team of partners. But the most important people were not the organisations that were around the table, but the volunteers who were out there doing the doing. It really was, and is, a social movement of local citizens, local people who respond to call-outs or shout-outs through social media, through the print and radio media, and give the gift of their time, energy, creativity, and compassion to support their others in their community. A whole range of initiatives that since its inception have developed over the time. A little bit of pivoting during the pandemic. Obviously, some of the face-to-face activities had to shift to more physically distant support. But despite that, and if perhaps not despite it, but perhaps because of it, has thrived and flourished and grown to the extent that it was decided that actually it's more than a social movement now, and now is a registered charity. To a certain extent, the evaluation has been iterative over the period of time. In the early stages, probably only about a year to 18 months in, my team with IFIC Scotland and some academic researchers did what was largely a qualitative report, reflecting on the individual, the relational, and the community outcomes that were achieved. Vast range of outcomes, from increased confidence, self-esteem, a sense of belonging, to that reciprocity between people who are receiving kindness and those who are giving it, to the community well-being, where there was a real sense of building that social capital in community, a community with a greater sense of hope. So all of that evaluation material is available, and was really pretty powerful in terms of, you know, all of those partners around the table. But to a certain extent, as we were beginning to move from a social movement where we had collaboration with some of the statutory organisations and potential funding partners around the table to being our own charity and being let go, we thought we'd probably need more granular evidence around the difference it's making. Yes, we know all about the well-being, the reduction in isolation, the sense of belonging, and the opportunity for people to, you know, to visibly show their caring and nurturing selves. But could we quantify that? Could we be a wee bit harder? Because when it comes to putting in grant applications, those of you in the room who are working in the third sector, I am as well working with my local hospice, we have to be quite hard-edged. I was very inspired by the comments this morning in the plenary about trusting the process and not necessarily needing a full business case to be, but you know, there's very few funding organisations or commissioning organisations that are in that ethical commissioning space. So how could we quantify some of that value and show that it was truly reducing service demands and costs? And I have to say here, full declaration, I'm not a health economist and none of my team were, and we didn't have the time or the budget to be able to do a really whizzy, glamorous economic evaluation, and I'm really waiting with bated breath to hear what comes out of the Flanders work so that we can stand on the shoulders of giants. But we were actually surprised by how relatively easy it was to find costs avoided. Once we started looking at the No One Dies Alone companions in hospital and at home, that was releasing a healthcare worker or a social care worker who was not required to sit with the patient and family. So once we started adding up those hours of volunteer support that released staff time, and we costed that, big costs avoided, Similarly with other initiatives, perhaps, you know, less costly staff time being released, but it all mounts up. Every penny counts. What surprised us, again, was, you know, we knew that the back home boxes, the boxes that people returning home alone from hospital got, regardless of age, with small essential food and items to help tide them over the first few days at home that can be quite rocky, as we all know, having been discharged ourselves or received family who've been discharged. We all knew that, you know, there were some benefits from these, but actually what really surprised us was the conversations with hospital staff who said, we're really confident in sending people home alone now because we know that, you know, they're going home with food and, you know, things to make a meal. We know that they get a get well card written by a local school child. They don't feel alone. And a subtle shift in the culture and practice within the hospital team. And you can see how well received that little box of love is by patients who are going home on their own, feeling quite vulnerable, but know that there is help there if they need it, and they could ask for a back home visitor if they feel that they are not immediately confident. And it's interesting that the orange line is the performance of delays in discharge home from hospital for the area compared to the national average, and the lower the better. And you can see Inverclyde was already a good performer, but you know there's certainly a sense that that trend is slightly widening, you know, but certainly we think that the delayed discharge performance is helped by having the back home boxes, so much so that the chair of the health board, you know, the partnership is only one of a number of municipalities in that big metropolitan health board area, said he wants this rolled out in all of his local areas. We tested some assumptions, and you know, you could say actually maybe these are still too ambitious, but we tested a range of assumptions with our chief operating officer for the hospital, with the discharge team, with the social care, home care provider, manager, and we came to an agreement where, okay, if we said even 20% of those returning home alone go that day and not the next morning because they're going home supported with the box and with what comes behind the box, that's big savings. And similarly, if we said that even there was a 50% reduction in the number of people who are getting a 30-minute just checking visit on the day of discharge or within 24 hours of discharge, then again, that's a saving. There were lots of other strands of work. The High Five Wellbeing Programme was particularly focused on children, primary school age children, as well as adults who are probably some of the most marginalised members of the community, staff in prisons, prisoners, people working with homelessness. We actually never quantified that. Because we just didn't have the time to go through all that, nor did we look at some of the individual and organisations' kindness awards. That was another strand of work. So people could nominate somebody in the local community who had really stood out to them and helped them at a difficult time. So here we see Charlotte, hairdresser, who really helped somebody cope with cancer because of the way she approached the hair loss and all of the self-esteem that goes with that. We didn't also look at the bereavement training that people had gone through as part of the organisation, Inverclyde's support and journey towards bereavement charter mark status. But we certainly, I think, over all of these other strands of work, were able to identify a huge amount of social value that had been created, very similar to the early evaluation from 2018. But we were able to quantify some of that social value. We looked at the Housing Association's Charitable Trust Social Value Bank, which is a great source of being able to put meaningful, quantifiable value against certain outcomes. It's a great resource. And we chose 2 outcomes that were commonly experienced by people receiving some of the initiatives. We looked at that feel belonging to a neighbourhood for the people who were attending the Friendship Hub. 45 individuals. The 1-year value was estimated to be just short of £4,000. That was contrasted with the other outcome that had a value, which was relief from depression and anxiety. So while the first one was probably more of a sort of chronic state, feelings of excluded and not belonging, so the intervention helped to address that over a longer period, we felt that we would only see maybe a short-term response or result from the intervention around back home visiting or palliative care companions or new mums companions, because we thought probably there was only a sort of transitional sense of well-being that was affected and then, supported. So we gave that a higher dead rate, a higher attrition, and we only said that there was about a 20% attribution to the intervention. There were other interventions that were at play for that particular group. So we took sort of 2 extremes of social value and we calculated that up. Once we did all the maths, we were able to say that, staff costs avoided and tangible benefits were estimated at over 800,000, and the more intangible benefits just from those 2 outcomes for a small subset of the interventions by the social movement was again almost £500,000. Total estimated social value, easily, conservative estimate, over £1 million, for annual running costs of about £82,000. So over the 5-year period, bearing in mind that, there'd been a lockdown in the middle of this, at least a 3-to-1 return on investment there. Now, as I said, I'm no economist, but this was good enough to really help the commissioning team, the Health and Social Care Partnership, who wanted to invest in this, but needed to have some evidence. And so for me, it's been a learning journey going through this piece of work. I think quantifying the value of an initiative like this is feasible. We learned that we shouldn't be too ambitious. It wasn't possible to measure everything. So we focused on some things. We started somewhere. We were quite clear about who we were trying to influence, particularly the Health and Social Care Partnership who were commissioning. So we focused on the things that we thought mattered to them, like the discharge from hospital. We have popped up the literature, the reference sites that we found very, very helpful at the Social Value Bank. And we learned that we had to have really honest conversations, that we weren't going to over-attribute effect to the one thing, because we all know complexity contribution analysis is what's really important. So we didn't over-attribute, and we felt that these of good enough calculations might actually be enough to convince funders. And actually, since we did this piece of work, we've landed a big lottery fund for 2 years, which is amazing, and also a health and well-being award. So just wanted to share that very pragmatic approach with you. I hope there's no health economists in the audience, but be kind to us. It's be ambitious, be courageous, and don't ever apologise for doing something that looks a bit soft and woolly, because when you get your head round it, actually, this is really delivering value. Thank you.
Thank you very much, Anne. A very compassionate story as well. Questions, remarks, suggestions? Yes, please.
Thank you so much. I always love the presentations from Scotland. I'm Pauline Pariser from Canada. The compassionate communities remind me of another term, resilient communities, and particularly with the predictions of climatic crises, further pandemics, and the impact on the vulnerable. I didn't see this, and it may be something you're considering, initiatives that would be proactive around inclement changes in air quality, in excessive heat. So I don't know if that's being incorporated or considered, but ways in which people who are vulnerable could be connected to resources early in those processes.
Yeah. No, what a great question. And I guess partly the absence of that is partly because some of the real challenges in that particular geographical patch are probably more around poverty and social exclusion and stigma. But you're absolutely right. When you look at some of the other areas of sort of caring neighbourhoods, caring compassionate communities around the globe, looking at climate challenges, as whether it be drought or fire, looking at what you've experienced in Canada, what our colleagues are generally experience in Australia, they're huge. That particular community, climate is not their biggest issue, but it's a great connection and an opportunity for me to advertise tomorrow lunchtime. We have a small island special interest group which is evolving to a remote, rural and islands special interest group. So come along tomorrow, look at it on the web pages if you're interested in that stuff, because that's what we want to get into. And we have, as part of that, we have the Seychelles. Last month I was talking with the WHO Afro Small Island Developing States Community of Practice, and that's the stuff that they're really worried about.
Well, next to that advertisement, is there another question? I have one last one for you. If you look at the other presentations that were about screening and assessing, and then I saw your whole list of very nice initiatives of all the volunteer organizations that took place. Is there a connection? Do you see a connection?
Yeah, absolutely. And one of the beauties of the arrangement that we've had is that the citizen-led social movement, the volunteering, is done in partnership with the Health and Social Care Partnership. And the Health and Social Care Partnership was very well led. The chief officer, who's now the chief executive of the local council, had a very mature approach to partnership, very similar to what we heard in the plenary this morning. Felt as if this was a partnership of equals. It wasn't the big organisation commissioning to small provider. It was genuinely understanding the value of third sector partners and genuinely understanding the power of local people to do amazing things.
Okay, thank you very much. This This ends the session. So I hope you enjoyed it. We had a good conversation from all around the world, and I think now it's lunchtime, and people are starving. So have a nice conference for the last 1.5 days, and see you all.
nicht diese Töne, sondern lasst uns angenehmere anstimmen. Und nicht diese Töne, sondern lasst uns angenehmere anstimmen und
It is 4:30 local time. I like to be punctual. So let's make a start because we've got a really full list of speakers for this session, which shouldn't surprise any of us, I think, in this session, given its title, which is Experiences of Whole System Transformation, one of those really knotty problems that we've been grappling with in integrated care for a very long time. So I'm going to introduce our first presenter, who is Stephen Gibb, and Stephen's from the University of Western Scotland. He's going to talk about care as a golden thread, creating and implementing a new national outcome on care in Scotland. And just before I hand over to Stephen, just to let you know, we're going to hold questions and answers until the very end. We're going to go through each of our 6 presentations, and we're actually going to have a panel discussion with you all. So if you have any burning questions, hold on to them, and we'll come back to them at the panel at the end. Stephen, over to you.
Okay. Good afternoon and welcome. I hope you all enjoyed a nice cup of tea and have got your burst of life for the last session of the afternoon. So, I'm going to talk about Scotland. I'm not going to go into a lot of detail about Scotland. You'll know something about it or not, but we're just about a 30-minute flight over the water there. We have, as I'm going to talk about, a national performance framework that the government as a whole created and has been reviewing, and I'm going to go into detail on that and explain why that links into care and integrated care. And I suppose there's a lot of smart people here, a lot of very committed people here doing all kinds of wonderful and amazing things around integration. But what I'm really focusing on is the care element, and talking about how with whole system transformation there might be an element of culture change required to create an environment in which care itself is much more visible and valued. And that's what I've been working with some other colleagues on, and I'm presenting on behalf of my colleagues Hartwig Powys, Chloe McLean and Nicola Hay, who've all been involved in this research. So at the moment, Scotland's had a national performance framework in place for some years, and that's broadly what it looks like. 11 outcomes in plain language, simple language, put there supposedly at the heart of government, and each of those has got a set of indicators associated with it that are publicly tracked, and you can go online and you can check, is it getting better, is it staying the same, is it getting worse? So the idea is to make it transparent and visible. There was a statutory requirement to review this through the period of 2023 to 2024. And at the outset of that, 3 years ago, I and some other colleagues in a variety of organisations concerned with care said there should be a care outcome in that framework. There isn't one, there should be. People might say, well, there's a bit here, there's a bit there, there's a bit... Okay, we need it pulled together, made visible. And a symbol, and behind that the indicators, the actual value of care itself. So we got involved to do that. Why? Because people were quite sceptical about the old national performance framework. They said it didn't really affect government policies, it didn't really affect budgets, but in the run-up to the review, there was a big debate about that needs to change. So the things that are in the national performance framework are those things which people will be required to think of as golden threads and must address, and budgets should follow that. So that whole landscape was going to become much more important. It wasn't just a bureaucratic exercise in refreshing a website. So because of that, we thought, again, that reinforces the idea that care should be there, because if it's not, then it's invisible. It's undervalued. And as I say, I'll use the word culture frequently. I think there needs to be a kind of cultural, environmental change in the long term for all the things that many people are trying to achieve with integration to work, because without that, the public don't get it and don't buy into it. Politicians don't get it and won't buy into it. Things will not happen at the scale and at the speed that they need to. So, I should be able today to say to you that there is a care outcome because the process is supposed to have concluded. I was talking to my colleagues there about this. I can't say that because the announcement on the new National Performance Framework, consultations closed, was meant to happen on the 28th of March.
Didn't happen. It was moved to the 5th of April. Didn't happen. It was moved to the 15th of April. Didn't happen. Still hasn't happened. The deferral of the announcement of the new framework, which has been agreed, and we know what it looks like, but it has to go to ministers first for them to approve it and then go through a period of parliamentary scrutiny in the months ahead. So I can't actually say that there is indeed a care outcome in the new national framework. There is. I hope that didn't go out on the live stream. In terms of what the indicators are and so on, I think that's one of the reasons it's been deferred, is because there's probably quite a lot of haggling and debate about that, because that locks you into things in the long term, and what those things are therefore become quite weighted. In terms of what we did and who we engaged with, we set up a campaign called the Scotland That Cares. We did this initially through our university as a partnership with Oxfam, and we put together a steering group with representative groups of carers and care organisations, including the private sector independent employers organisations, Scottish Care, Carers Scotland, and various other groups. And over 3 years with them, we engaged in a variety of things and created what we believe has been a successful campaign. We enrolled an awful lot of other organisations to work with us. Some of the logos are there. We did a huge amount of in-person lobbying. We did a huge amount of social media and mailing lobbying, and all that seems to have come together really quite successfully. What did we do? We actually, at UWS, produced a report that underpinned the campaign. We did some research around literature, interviews with stakeholders that said this is what the outcome should read like, these are what the indicators might be, this is why we should have a care outcome. We should all have a care income, but we should definitely have a care outcome. In terms of the actual results that we got, as I say, we went through the phases of the campaign, we went through all the steps, we had loads of assets and activities, lots of advocacy hooks and outputs, lots of promotional opportunities, and it was a very positive and hopeful thing to be involved in over the last 3 years, when so many things have been the opposite. And we all know that the resource pressures and the system pressures that there are in Scotland is certainly not exempt from that. But this really felt like something that was positive and hopeful, and that was about trying to create that environment for the future, despite the challenges of the current environment. So, yeah, there should be next week, by the end of April, Maybe. In terms of the impact that we had, we have a pending care outcome in the MPF. And as I've mentioned there, I think that's generated a lot of positive energy and hopefulness amongst a lot of stakeholders and people who were otherwise, as I say, dealing with really quite challenging times and circumstances. That's not a bad impact to have. The real impact, of course, will be once it's in, and does it change policies, does it change budgets, does it help actually move people into that environment where care, by being more visible, is more valued at the heart of government all the time, and not just when there's a bad news story and there's a crisis of some kind. The next steps then, to almost conclude, we await the official announcement, and when we do get that official announcement, we will celebrate it. We will be so happy. I'm so disappointed that I wasn't able to get drunk in Belfast with people at this conference in order to help celebrate this. That's the thing that deferring has meant most to me. Beyond that, we want to shape and decide the outcome indicators. They will be up for debate in the next 4 to 5 months. Quality of care, outcomes, paid and unpaid care work, education and professional development. Those are some of the themes that we would like to see put in there as indicators that would be visible and transparent and tracked. And follow that through on, will this revised MPF actually have the kind of impact that we want on government and policy making over the longer term. Not only that, we'll be able to share the full story once the eventual MPF is verified in academic publications and at other conferences, and learn from that and encourage others to maybe explore similar campaigns and similar thinking and similar ways of trying to create that environment and culture change. Because we looked at the Scottish context and said, care is not visible, care is not there. Once you begin to see that gap, you see it everywhere. There's a World Health Organization. There's not a World Care Organization, is there? with social care as equally prominent and valued as health. In the UN Special Development Goals, again, you can pick out little bits, but there's nothing that's specific. And I think, for public policy reasons, for workforce reasons, for other reasons, care must be much more visible and valued. So there's a whole journey still to go there at a much larger level. And a final point, which I'll conclude on, in the plenary yesterday, a lot of interesting things were said, which just ticked a lot of boxes for me and inspired a lot of thoughts. But one thing that was said was we need to shift from distributed leadership away from individual heroic leadership. And I absolutely agree that that's true, but they're not opposites. And one of the things that this campaign has shown me and taught me is that you need some individual heroic leaders. I'm not one of them, by the way, I'm just the academic. But there were several others in this campaign who were amazing individual, resilient, determined, committed, heroic leaders. And we need to nurture and develop those as well as our distributed leadership capacity in campaigns like that. And it's a good way of doing it. And that's me.
Thank you very much for that, Stephen. And as I say, we're going to hold questions now until the end, because next up we have Hannelore Gewerts, who is from the Federal Public Service Health Belgium, and she's going to speak to us on the transition towards integrated care in Belgium. Over to you.
Thank you. Okay, good afternoon, everyone. Thank you for the short introduction. I will briefly guide you towards the transition towards integrated care in Belgium and talk to you about the evolution from local regional pilot projects to a national policy plan. As a short introduction, some insights about the history of integrated care in Belgium. I think Jan de Mazeneer already gave us a very nice insights and info about the 20th century in Belgium. Here on this slide you can see some important milestones for the 21st century. So in 2008, for example, we had our first national plan with priority to chronic diseases. In 2010, we had our first pilot project for integrated elderly care, in which case management had an important place. Also in 2010, we had the start of our mental health reform. We had our first action plan for e-health in 2013. And then in 2015, we developed a joint plan for chronic patients. And this plan I would like to discuss a bit more into detail with you. So the joint plan for chronic patients was the first basis of collaboration between regions, communities, and the federal government for integrated care in Belgium. Because as you might know, we're a very small country, but we do have 8 ministers for health, so you really need to make good agreements and structure collaboration. And the mission of this plan was to obtain a better quality of life of the population, especially for persons suffering from 1 or more chronic diseases. This plan consisted of 4 action lines to support the development of integrated care, and the most important action line was the creation of 12 pilot projects for integrated care that started in 2016, and they were created to really experiment with integrated care initiatives and collaboration at meso level. In 2023-2024, they turned into partnerships integrated care, and I will tell something about it later. So the pilots had their executive phase from 2018 to 2022, so a period of 5 years. And as I said, they were testing actions for integrated care in a number of regions in Belgium. So on the right side of the slide, you can see the repetition of the different projects, and each project covered a region from 100,000 to 300,000 inhabitants. And they were all supported by a network of actors from different sectors, including primary care, hospitals, patient organizations, etc. And some projects created their own legal entity. Others, they were attached to existing legal entities like hospitals or other organizations for healthcare. And their common goal was to contribute to quintuple aim. If we have a look at initiatives they took during those 5 years, we saw that they really created a large connection between health and well-being partners in their regions. One of the projects invested also in primary care neighborhood teams, and this project was also selected by IFIC as a case study for the connection between between primary care and secondary care. They also had a lot of initiatives for informal carers, like boot camps, courses to inform them and to support them in their task. There were a lot of initiatives around case management and care coordination, also around transmural care and goal-oriented care. So what did we learn after 5 years of executive phase of these pilot projects? Multiple initiatives for evaluation were taken before, during, and after this executive phase. And for process evaluation, we used annual reports. So each of the 12 projects made an annual report where they reported about their lesson they have learned, for example, their communication plans, their strategies, their use of resources, etc. They also registered their included chronic patients in their projects in a digital tool, and we also organized monthly intervision moments with the coordinators of the projects to exchange about obstacles, difficult subjects, to facilitate the exchange and to find solutions. They also had a self-evaluation approach, but it was a bit different for each project. And there were some initiatives for outcome evaluation for the projects. There was, for example, an evaluation of quality indicators like readmissions in hospitals, polypharmacy, or readmissions to the emergency department. But it's really hard to make hard conclusions because we had a lot of heterogeneity between the activities of the projects. Sometimes there were small sample sizes in their activities, or it was a short time frame for the execution of the activities. There was also a lack of baseline data. There was no 0.0 measurements, and we also had the complexity of the quintable aim evaluation due to external factors, for example, the COVID crisis. Although we lack the hard evidence for these pilot projects, we are really convinced that these projects had an added value for integrated care in Belgium. On one hand, we really see them as having a key role at meso level. And on the right side of this slide, you can see that in Belgium, we already have a lot of structures, a lot of territorial approaches like hospital networks, mental health networks, primary care zones, etc. And they all have different boundaries. These projects really took the role as a sector and line independent position. They really had in their zone the helicopter view over all these initiatives. And they facilitated also joint initiatives between all these structures. So this build-up of the cross-sector and cross-line network, we really want to preserve. On the other hand, they also conducted a lot of innovative activities at micro level, so they really had implementation power to go experiment with integrated care initiatives on the field, like community care initiatives, care pathways, initiatives to optimize the use of medication. And also for these activities, we are looking together with the entities how we can sustain valuable initiatives. So the executive phase of the pilots is already over. In 2023 and 2024, the pilots are in a transition phase because we want to move over to a more structural approach. We want to let go the pilot phases. And we are trying to prepare the transition to a more structural framework, which will be translated in our interfederal plan. So now we will go a bit more into detail about our new interfederal plan. So the goal of this plan is to organize broad and sustainable implementation of integrated care in Belgium through structural collaboration at macro level, because that's what we learned as well the last years. If you want to go fast, you can go alone, but if you want to go far, we really have to go together in Belgium to work on integrated care together. So what is the difference with the joint plan for chronic patients of 2015? We feel that we really have like a stronger mutual commitment of the federated entities and the federal government to create more integrated care. We also created a shared legal framework with 8 agreements we share, always in close collaboration with the responsible meso level of each entity. So each entity in Belgium identified a responsible or reference meso level for integrated care. This plan will also be aimed at the entire population instead of only to chronic patients, but there will be specific initiatives for certain priority target groups. And in this plan, we will try to connect health and well-being sector through common interfederal programs for integrated care in whole Belgium. And these will be co-financed by the federal government and the federated entities. And the co-finance will be used for initiatives for coordinated care and, on the other hand, the organization of integrated care at meso level. And yeah, we will try where possible to base us on the good practices from the initiative existing before. Before going to the next steps for 2024, this is something we want to share with you. So we had a lot of stakeholder discussions already in the process to come to our interfederal plan for integrated care. And in these discussions, we actually came to 10 missions of integration management, or 10 missions you need at meso level to implement integrated care, or 10 missions that are crucial for the implementation of integrated care. So you can see it as a temple, and on top you have a roof of population health management that is really steering down for the other pillars and components. On the base we have change management and innovation management that will be needed to create or facilitate the pillars that are in between. Yeah, I think I can read them all, but I don't know if we have time for that. So I will go to the next slide. So what are our next steps for 2024? We will work further on our interfederal governance model for the implementation of this interfederal plan. And we will be developing 3 interfederal programs for the following target groups. So the first target group is perinatal care, or the first 1,000 days in life, because we also know that this period in life really determines the days that come after. So it's very important to well organize these first 1,000 days. Vulnerable persons and obesity in children and adolescents. And then last but not least, we will also enhance the assigned meso levels by the different entities following the 10 integration management missions and taking into account the good practices of our current initiatives. So this was our presentation. Thanks a lot for your attention and to be present here. Thank you.
Thank you very much, Hannah-Laura. And just a reminder, we do have the Q&A in the app, so if you are thinking of any questions as our presenters go, please do put them in there. And we have a roving mic. We will come round to you when we get to the panel part of our discussion. Okay, next up we have Vicky Sarah-Sutton, who is from the Agency for Healthcare Quality and Assessment in Catalonia, and she's going to speak to us on advancing in the identification and assessment of integrated social and healthcare experiences in Catalonia.
So thank you very much. This is the first time we will be presenting these results external from the research team, so I'll be presenting in. It's a very good challenge for us, an opportunity. I don't know if you've ever been to Catalonia. Barcelona, you know. So today is a festivity, it's Sant Jordi, and everybody in Barcelona is in the street sharing books and roses. Just a little bit about the context of our commission project. During the last decades, there has been the promotion of initiatives of integrated care, not always called as integrated care, but strategies of collaborative models between social and health care. And more recently, there has been even the promotion of a common agency of integrated care from Health Department and Social Rights Department, specifically starting in 2021. And then the role of a new professional that is at regional level, we call RISE. And it's a professional that is a reference of integrated care at regional level. So in Catalonia, there are 9 health regions and 9 social regions. These professionals pushing forward integrated care at regional level. So we, as ACWAT, were commissioned exercise of mapping and assessment of integrated care experiences from all Catalonia and all regions, very closely to the starting of implementation of the strategy at macro, meso levels. So we have been working together, as you see in the road, at macro, meso, micro level in this assessment. And we had 2 goals. First, to identify experiences of integrated care, social and health, or only social or only health, from 3 different priority lines: home care, nursing home care, and also mental health care. And then describe them in more detail, classifying them according to different characteristics. Which was the methodology used? We used a mapping exercise implying a qualitative study, a phenomenological qualitative approach, starting in 2022 with the identification process. This was quite challenging to identify experiences that met the inclusion criteria. Described them very basically, and then when we identified that they were active, we did another in-depth interview using questionnaires, checklists to understand their maturity, and additional information. In fact, we've only finished our fieldwork interviewing the different experiences. RISE, the Territorial Reference of Integrated Care, did the interviews to the co-leaders of the experiences. Once the active experiences were identified and we assured that they were integrated active, they carried out this interview. We coordinated from ACWAS the fieldwork and also carried out an independent basic descriptive and also content analysis. An important thing is the inclusion criteria. Why? Because we wanted to include and be exhaustive in identifying experiences in these 3 levels, or 3 priority lines, where also the technologies, communication technologies were cross-sectional. And we wanted experiences that were from at different levels of deployment, from basic identification needs to more advanced, even evaluated experiences. And also, and this is an important point, the criteria, a common criteria to consider an experience being integrated, shared a model of care, involvement of at least 2 services of the health sector or health and social, and coordination among professionals in the same model of care. So some very descriptive results. We identify 144 experiences, and from these we could see that according to these criteria, They were active, 82 were active, and 62 were willing to have an in-depth interview and a collection of information, mainly from home care and nursing home care. In this figure, there are the 62 experiences classified according to the level of deployment level and also the perceived level of integration. This classification was in the semi-structured questionnaires, but it's a perception of the experiences of the level of deployment and integration. And as you can see, most of these experiences were classified as a moderate or advanced level of deployment with some heterogeneity because some are behaving more as a lower or perceiving they have a lower level of integration or even higher behaving as more advanced experiences. In this other table, some results comparing this deployment level with the availability of management or implementation tools. And as you can see, more or less 50% of experiences have an agreement or institutional agreement to work together, and even less have, for example, functional plans or shared information systems, application of ICT, or experience being assessed. There's a little about the population being attended, that's descriptive. In the case of home care experiences, most were attending older people and adult, also of course nursing homes as we expected. And in the case of the experiences in the priority line of mental health, mostly were addressed to adults and teenagers. And a final result, that is, we classified the goals of the experiences and the expected results. We asked them, each experience, to express what they were expecting as consequences of implementing their model. And we classified this information in 8 big groups. This is very preliminary. Just to note, this point 6, the promotion of empowerment and autonomy of people, as I think the basic goal to keep people at home. This is the experiences addressed only to home care as a priority line, to keep people at home as long as possible. As conclusions and key learnings, to our understanding, this is the widest mapping exercises in the context of Catalan health and social system. Mostly are in the home care and nursing home care strategic lines. Most of these are horizontal, meaning from 62, approximately 80% are horizontal, including social services and health services, are in the moderate level of deployment, but curiously, low have functional plan or shares information system, or even they haven't had a formal assessment of these experiences to improve. And during these 2 years, one of the challenges, I think, and the learnings has been to put together what common criteria are of what is integrated or not, what is even the level of deployment, sharing information of the services from the health sector and the social sector, so a big learning knowledge transfer. And then there are still challenges to classify them according to the maturity, in which real level of deployment they are, which are the needs, and how they can evolve as best practices, and the criteria to consider them best practices. So as a colleague from Belgium, I also reinforce this sentence as a process. As a journey, it has been a very collaborative experience. So thank you very much for the opportunity to share the results.
Thank you very much, Vicky. And a reminder again to put your questions in the Q&A. I have mine stacking up, so if you don't get in there quickly, I've got a lot that I want to ask. So the next presenter we have is Chris Naylor from the King's Fund in England. And by the way, any of our English colleagues, clearly the Barcelonans know how to do St. George's Day. The development of integrated care systems in the English NHS. Progress so far and challenges ahead, not a small topic.
One second. Thank you, Niamh, and thank you to all of you for coming to this session and turning out for the 4:30 slot. So I work at the King's Fund, which is an independent health organisation charity in London. We've been quite closely involved with the development of integrated care in England over the last 15 years or so. My role in the King's Fund is to lead some of the research and policy work that we do around integrated care. And I'm going to be talking today about the development of integrated care systems in England, what we've learned through our research on ICSs, and to give a bit of an assessment about how it's going so far. And if I give you the sort of main conclusion from this presentation first, I think there's some really fantastic work going on in ICSs in England at the moment, and I'll share some of that with you. But I also think there's a real risk that these reforms don't deliver what they were designed to deliver, in large part because of the very difficult context that we're all working in at the moment, and the way that those pressures are driving behaviours at all levels in the system. So I think we're at a point where we need to work really hard in England to make sure that we keep these reforms on track. So, integrated care systems are partnerships which bring together all of the organisations you can see on this slide. So it brings together commissioners, purchasers of care with the providers of care. They bring together NHS organisations with local government and with voluntary sector organisations and other partners. And they bring together all sectors of the health system, really. So hospital care, primary care, community care, mental health care, and so on, social care. And the idea of them is that by working together, all of these organisations take on a collective responsibility for understanding the needs of the local population better, and then devising a strategy for meeting those needs better. So in other words, when these organisations come together, the purpose is to think, how can we use our collective resources across all of our organisations, across the whole system, to meet those local population needs better? Now, we've had ICSs in England in some form or another for almost 10 years now, but for most of that time, they were informal partnerships. They were people doing it on top of their day jobs. They didn't have any legal powers or budgets or duties. That all changed 2 years ago in July 2022, when the government passed a very significant set of legislative reforms, and the main thrust of those reforms was to give ICSs legal powers and budgets for the first time. So ICSs now control the majority of the NHS budget in England. The previous commissioning organisations, the purchasing organisations, clinical commissioning groups have been abolished, and ICSs have taken over all of their responsibilities. And we have 42 ICSs covering the whole population of England. So to give you a sense of scale, each ICS, they vary a lot, but they cover a population of around 1 million or 1.5 million on average. So this is what ICSs have been set up to do. We've been following the development of ICSs over the last few years, particularly since they became statutory organisations. And we have 3 research projects which have completed recently or will be completing in the coming months. The first is looking at ICSs through the lens of workforce. So we've been doing some case study research looking at what are ICSs doing to tackle the workforce challenges facing the health and social care system. How are they bringing together all of these different partner organisations to develop more of a whole system response to workforce challenges? So that report is going to be published on our website in June. The second project that I'll touch on today was using a lens of a particular clinical condition, dementia, and saying what are ICSs doing to help improve dementia care and dementia diagnosis in particular. So that was published last week. Again, it's on our website. Links to it are included at the end of my slide set. And then the third project is looking at how are ICSs organising themselves to try and promote partnership working at more local levels, a smaller geography within the ICS that we use the word place to refer to. So place-based partnership working within ICSs, how is that going? That project's still ongoing, so I won't be saying much about it today. But really, I'm going to cover two things in this presentation. So firstly, what are we seeing in our case study sites that make us think ICSs are really adding value here? And there's, what are the roles that they're playing? And then secondly, what are the things that we're hearing in those case study sites that are holding them back? And in particular, what are the things that national organisations could be doing to create an environment that's more conducive to their success? So in terms of the ways that ICSs are supporting integrated working, in our research we identified 6 main things that they're doing. So firstly, they are helping partner organisations within the local system to organise around a shared purpose. So if I give you an example relating to workforce, in lots of ICSs we're seeing the different partners coming together and saying, let's do more to grow our own local workforce. So let's work with higher education institutions and schools and local job centres to try and recruit people, particularly from the more deprived parts of our geography, so that at the same time as meeting our workforce needs, we can also create meaningful work opportunities for people who might not have had a pathway into health and care jobs previously, and by doing so helping to tackle health inequalities. So that's one example of something ICSs are doing to create this sense of shared purpose across all of the different organisations. Another one from our work on dementia is around giving visible prioritisation to dementia and saying, actually, this is something that as a system we're choosing to prioritise and really have a push on. The second thing that ICSs are doing to support integration is about building systems leadership, so providing training and development in system leadership skills, creating a more diverse leadership community. So often ICSs have been looking at the power balances within the system that you sometimes see, and trying to deliberately give more voice to parts of the system that have tended to be less powerful in the past. So voluntary sector, for example, or primary care, social care. The third thing that we found ICSs doing was around encouraging system-focused behaviours. So in the NHS, we've had a legacy of 30 years where the policy focus has been on the internal market, trying to get different NHS organisations competing with each other to drive up quality. And NHS leaders are still held to account, first and foremost, for the performance of their individual organisation rather than the wider system. That's changing. Regulators are changing their approach, but it's changing slowly. And so what we see is lots of what I would call organisation-first behaviours still persisting even within the ICS environment. But ICSs, we saw, are trying to challenge those behaviours. They're trying to instill collaborative behaviours and values. And that can be as simple as bringing together the different partner organisations regularly, trying to build relationships and trust between the different leaders involved. The fourth thing we saw was ICSs trying to spread and scale success. So if we take another workforce example, we saw in our case study sites them developing a shared approach to staff health and well-being across the whole system. So regardless of which organisation you're employed by, you have access to the same support for your health and well-being. Using resources differently, that was part of the rationale for setting up ICSs in the first place, was to enable organisations to make better use of their collective resources, and we saw some examples of that. It's difficult at the moment because the resources are so tight, but we did see some examples of where, for example, a system has made a collective decision to try and move resources upstream to do more on prevention. Finally, managing complexity. So we think that the ability of ICSs to manage complexity is one of the key factors that will determine their success, and we saw them doing that by supporting people to understand the complexity of the system they're operating in and to make connections across it. So those are the 6 things that we saw ICSs doing that seem to be adding most value to the work within their local areas. And one of the things that we were really struck by looking at those 6 things is that a lot of this is hidden work. These are not things that are easily measured, but they're vital. They are the invisible infrastructure that integrated working depends on. Turning to the second thing I wanted to talk about was, as well as hearing some of those really kind of positive stories of where ICSs have been helping to move things towards a more integrated approach, we also heard a lot about the challenges that people have been encountering trying to do this work. And so we asked in particular about what national bodies could be doing to create an environment in which ICSs have a better chance of success. And really, we identified 3 things through the research we've done. There's something about realistic expectations, about approaches to accountability, and about a more flexible funding model. So in terms of realistic expectations, the timing for these reforms is really important. I mentioned that ICSs took on their statutory powers 2 years ago, and the last 2 years have been among the hardest that the NHS or health systems globally have ever faced. We've got an exhausted workforce, we've got huge waiting lists, money is extremely tight. And what happens in these kinds of circumstances is that people's behaviours change. And they change in ways that sometimes makes integrated working harder rather than easier. So organisations become more protective over their budgets, for example. So this quote is from one of the case study sites where an interviewer was saying, we've probably never experienced it as bad as this, as it is right now in terms of recruitment and retaining staff. And then trying to make the biggest transformational change in our history, when your back's up against the wall, you need to do what needs to be done in the here and now, and sometimes that longer term vision gets lost. We need to make sure that national bodies have realistic expectations of how fast ICSs can deliver, because if their expectations aren't realistic, sometimes that can be counterproductive. In terms of accountability, I was really taken by the phrase that Raphael Bangoa used yesterday about how we need to be tight on outcomes, but loose on the means for achieving those outcomes. Unfortunately, I think what we see in the NHS in England at the moment is the opposite of that. We're seeing a lot of central control because of the financial pressures and the political pressures. We're seeing a lot of grip from national bodies, and I think that risks stifling local innovation. And I think there's a fundamental mismatch in scope between ICSs and NHS England, which is the main national body that oversees them. So ICSs are intended to be whole system bodies, but they're held to account by NHS England, which is focused on the NHS. And that drives a kind of NHS centricity that we saw in lots of the system conversations in our case study sites. So again, this quote here, we came into this role full of enthusiasm for the opportunities it brought to truly look at cross-system workforce development and the fourth purpose of ICSs, which is all about contributing to local social economic development. But actually, it feels like we're being stuffed into an NHS England performance box. Finally, on funding, lots of the funding that's available for ICSs to do new and innovative things has lots of strings attached. It's time limited, it can only be used for certain purposes, and it comes with a huge amount of reporting requirements. And so what we heard from our case study sites was that they could be having much more impact from the same amount of money if they had greater freedom over how to use it. I'm just going to conclude with a few final reflections then on progress that ICSs are making so far. I don't want to be too downbeat. I think progress really is being made. There are examples of organisations coming together and working together more closely through ICSs, but it is slow and it's hard work and it's not linear and it's patchy across the country. This point that I made at the start, that the political and economic context risks derailing the original purpose of ICSs, and I think part of that is because of behaviours of leaders. I think will be the thing that makes or breaks ICSs, and some of the behaviours that we see at the moment are unfortunately reinforcing the primacy of national priorities over local priorities, and of NHS targets over wider system goals, and of clinical care over population health. I made this point about how some of the work that ICSs is doing is hidden and invisible. So when people ask what I think of as being the Monty Python question, which is what have ICSs ever done for us, it's important to remember that a lot of what they're doing is under the surface, but that doesn't mean it's not valuable. Giving ICSs statutory powers 2 years ago, I think, has had pros and cons. So some of the people that we talk to say that it's allowed them to take forwards their work on integration further and faster, but others say that it's set them back, at least temporarily, and that all of the organisational upheaval that came with the reforms has meant some of their more transformative work has been put on hold. One of the tensions that we see system leaders grappling with is this ambiguity in the role of the integrated care boards that sit at the heart of ICSs. So they have a dual role, both as a facilitator, a convener of the system, but also as a performance manager of some of the organisations within the system. I think that balancing that dual role is proving really challenging for leaders to balance, and I think that needs some more thought from policymakers. And then finally, it's been a tough few years, hasn't it? And unfortunately, the next few years don't look particularly cheery either. Certainly, in terms of the money, that's not going to improve significantly over the next few years. So I think we have to hope that those pressures create a burning platform for change rather than just burning the whole thing down. Thank you very much.
Thank you, Chris. And now we're moving from, I think we started out in Scotland, then we moved to Belgium, then Catalonia, then England. Now we're moving to Canada. And we're going to hear from Melissa Chang and Sharon Ozex about creating the conditions to advance integrated care, the University Health Network's journey to change how care is experienced in Toronto. Over to you, Melissa.
Thank you. We're going to do this jointly. Thank you, everyone, for being here for the last session of the day. Appreciate the time. I think hopefully you'll see a really nice complement between the presentations. There's a lot of overlap for sure in what we'll be talking about. We are going to focus a little bit more on the how and the impact that we've started to see in the doing and what that's meant for systems change overall in terms of an experience. So I will turn to you. Great. I didn't do introductions.
I think Neem did them for us, so I think we're okay. Plus, our pictures are nice and big on the screen. So again, welcome, thanks for coming to the last session, and also a warm welcome to everyone on the live stream, especially our teams back in Toronto who've joined the live stream and are participating and have supported all this great work. As Melissa mentioned, we're gonna pack 15 years into 10 minutes, so buckle up. It's gonna be light and tight, and we're gonna have lots of information to share after. Melissa, do you have the coaster? We have connected care coasters with our information, so we'd love to connect with you after the session, at the dinner, or after the conference, and share more about our journey if it's helpful, and also we're hoping to learn more as well, and that's why we're here today. So a bit of context around Toronto, and I know there's a ton of Canadians here at the conference, so I'm sure if you're not from Canada, you're learning lots of interesting facts about the place we call home. I thought I'd add to your fun facts of Canada and a fun fact about Toronto. Oops, I don't think it's on here, but Toronto has the only castle in North America. Is that a new fact for everyone? Yes. Also, Toronto is made up of about 6.7 million people. It is the most diverse city, I would say, across the world. When we look at some metrics such as percentage of immigrants in our population, Toronto in 2021 is at 47%. So that puts us ahead of London and Singapore and New York City as well. When you look at our population and our urban density, we're facing the same challenges and constraints that many other cities and countries are facing. And we've highlighted some of those facts here. We have a population that's increasingly aging. By 2031, 1 in 5 residents will be over 85. We're having our residents live longer with much more complex and chronic disease. We're also seeing a decrease in social connections, and you'll see that we're at 59% in terms of the metric of where people say they have someone to depend on. And we're also seeing, like other big cities, a crisis in affordability of housing. What underpins all of this for us is the lens of equity. We know that health and social care must meet people where they're at. And when I look around the room at my colleagues from UHN and across the city and the province, we're all very focused on that equity lens in terms of putting in access and outcomes that can support in partnership with the community. And that's a key focus for us as we go forward. What we've also realized in our time working at UHN as a multi-hospital quaternary network is that what happens in our hospital is a direct reflection of what happens in our community. So 15 years ago or so, there was a conscious decision to initiate and establish a strategic business unit that essentially is a dedicated backbone team called Connected Care that really works outside the walls and helping to integrate health systems as well as integrate across the communities. And that's been an area that Melissa and I and many of our leaders who are here with us today, it's a privilege in our position to help support and partner with our community partners. So this is our team, which has ebbed and flowed through the years as health system priorities have come and gone. When we've looked at the work that we do, we've really made sure that we were looking at this at a scale, where we've built relationships and trust across our sector with all of our provider teams, and that's been the key ingredient for us to be able to scale out many programs. Our journey started really around digital. In the early years, there was a significant gap in our digital infrastructure. So when we're looking at our care teams, again, from primary care all the way to long-term care and acute in the middle, as a patient presented in any particular context or setting, their information didn't follow them. So there was a government and system priority that Connected Care led to establish longitudinal electronic health records across the province. We've also established imaging and lab repositories to ensure that that access is also available to all clinicians across the system. And that journey took us 10 years to get to where we are today. The journey isn't done. We're still focused on e-referral systems. We also still have a gap in our primary care engagement as well as our home and community care, and those are efforts that we're continuing on. In the past 5 years, we realized that digital alone could not really fulfill our principles and our mandate around an integrated and authentic co-design of a care pathway. And that's when really our journey around integrated care began. And I think it's a good segue, Melissa, for you to tell us what the last 5 years have been all about.
I won't be quite as quick. So that was 10 years of our journey that we just went through. I'm going to focus on the most recent 5 years, which is really where we started to get into much more integrated models of care. And so when Joanna was talking about Toronto, I don't have to tell everyone in this room, really the core and the sustainability of integrated care systems really lies in our community, and for that work to be led from primary and community care. We have a really unique vantage point in that we are a regional delivery partner as well. So we've had the advantage of creating these relationships across the system, not only seeing the amazing medical, clinical advancements within a quaternary organization, but we also are, one of our sites is a community hospital. And so that's really where we're grounded in that. And the reason why we focus on the City of Toronto and 6.7 million is our referral pattern. So if you look at the data, we've got about 75 to 80% of our population is right across the City of Toronto. And that's even higher when you go to more medical chronic conditions, closer to about 90%. So when people talk about what community do you serve, that is the community that we serve. Those are where our patients are really coming from. I'll look here. So in the past 5 years, I'm going to focus, we've created a lot of partnerships, but I'm going to focus on our most mature care model, which is really from acute care out to home with a huge focus on home care. But of course, we've grown since then, but just for the purposes of time and making it a little easier to understand the examples, that is where I'll focus on, and happy to chat about other partnerships as we go. The key challenges shouldn't be of any surprise, I think, to anyone around the challenges we hear. When we embarked on this, we looked at a few things. Our province had just done a massive survey of patients to understand what are your most common concerns when it comes to seamless transitions in care. And by far, 70% plus said my biggest fear is leaving hospital and what kind of home care am I going to receive. So that helped us to look at prioritizing what is the biggest need that we'll need to look at doing. The other ones should be kind of self-explanatory around coordination, communication, continuity of care. When we looked at our survey results at the hospital, they really highlighted a few things. One is, when I'm thinking about home care, on the one side, our inpatient team tells us I'm going to get these services, and then they're nowhere near that once I get home. Equipment, supplies are not there. I get way less visits if I get them at all. So that was a huge piece. How do we make sure that our system will actually deliver the care that people are expecting and actually need? The other is, from our care provider's perspective, how do we shift it from being a task-based, I'm going to show up and help with this wound, to actually holistic care where someone can be there and see them in the home every single day to see the kind of changes that are happening over a period of time. And so that was the second piece. And then the other will come to the flexible, personalized care. And I really, Chris, from what you were saying, that flexible funding is really critical for us on system-level change. So those are the key challenges we started to look at. On this other side is aspirational goals. So every pathway, every partner that we work with has to commit to these goals. And when we talk about standards and best practice, this is really what we expect that our care providers and our patients and those we work with can expect from us in this model. So what do they want? One single point of contact. That is one person that follows you. If you don't know what's happening, it will be that person that you will contact. And so our time frame, if I look at this acute return to home, is as soon as you have an interaction with the hospital all the way up to 90 days. So there's one person there. I want to know who to call. I want 24/7, and I want a live person answering it. So there's always somebody on the call that's an in-person, answers the call, and if we need to go to a clinical support, there is nursing on call there. So every person gets a 24/7 phone line. We sometimes get calls in the hospital where people don't know who to contact. Like, I'm here right now. I don't actually know who I'm talking to, which is quite sad, but you can see how that might help in terms of anxiety. Some of these are aspirational. We all commit to response within less than 30 minutes, whether that's a patient calling into the line or a care provider in the home calling for a specialist. So that is our goal. This will be one of the things that our clinicians tell us, you are crazy and it's going to take us years and years, but we've all committed. They've actually signed with us to say we will continue to do this work until we get there. And then the last few are, clear action plans and escalation paths, so not having to wait for medical directives if they should exist already. Direct care or admission, so that is no using of the ED unnecessarily. So of course there are reasons why people will need to go to ED, but how can we look at when someone leaves, avoiding that, going back to overburden, increase the wait time. So things like opening up outpatient care, really direct clinic pieces, and that piece has actually been one of the easiest pieces to do because people are quite open to saying, oh, you know, some clinics will say, I'll open up a couple extra hours in the morning for integrated care patients, or extend, or we'll prioritize those people coming in so they don't have to be readmitted. I better speed it up. I'll spend a little bit of time here. So when we talk about the system-wide integration, just very high level, for time's sake, I didn't include a whole pathway. But essentially, as upfront as we can go in the pathway, some of them are originating from the hospital. So it could be at an emergency visit, it could be at a decision to operate. It could also be in the community where we're making sure somebody wants to stay at home, but maybe they feel like they're at risk for a fall. We start right up there. So that's when you get introduced to your person. That's also when you get introduced to the 24 phone line. So we can do things like look at prehabilitation, a lot more prevention and promotion activities. And then we follow the person all the way through up to 90 days. That's up to, we don't keep everybody necessarily for that. There are also cases where we have to make the call on whether or not that person would better benefit by being at home, and we extend the services for longer, or they need to kind of re-enroll into a different kind of stream. So one team up top, I won't spend as much time on all of them. I think some of the other presentations did a really good job on a few key pieces. But the one team is critical. So we have this one contact who's the navigator coordinator that's prime. They are a designated medical professional, so it depends on the pathway. Some may need more nursing, some may need more physiotherapy to support the pathway. But that is one person that is embedded with, in this case, the inpatient team. So they get to know the team. The team really is very confident that they know what happens from specialty care. And they are the link also with our home and community team. The co-design that happens is really the magic and the beauty of this, because rather than us saying, you have a single point of contact, I'll be the coordinator between the two, the teams actually come together to create the pathway. So we actually walk through what happens in home or in the community. How can we do it differently? Does it have to be that person here? That's where we really start to see, from a capacity creation level, we can have people be in hospital for less time. The other part of it is, as they're developing it together, there's a lot of trust that builds. So our clinicians, say in the hospital, will say, oh, I know exactly that they're going to get the care now. I'm not going to have somebody come back and say, you sent me home, you told me I was going to get a nursing visit every day, and that never happened. Because that starts to happen, there's a lot more confidence in, yes, I can now send this person home as quickly as possible where they'd like to be. The other is that the care teams work together around avoiding readmissions as much as possible. So there's much more timely attention to how that person is doing. So if we have a PSW, personal support worker, I don't know if the language is different in other groups, but if they're seeing somebody every single day and they're the eyes and ears of our team, they can tell us if that person is starting to experience some changes, and they can call in and say, I think we need to make some course changes, and how do we do that? And so they really do that as one team, and we get to more timely interventions, and then also where we can avoid it, we can send a nursing visit or something like that to avoid coming back to hospital. So that's critical around the one team. The other is the standards and best practice. I think Chris spoke a little bit about this as well, but we talk a lot about self-management, and we talk a lot about empowering our clinicians to be able to do this. But if every single program and every single pathway is different, how do they remember what to do in what area? We work with a lot of older adult populations, and they like to share with each other. Oh, I went to my doctor, and this is what happened. This is the process. Here's who you have to call. They can't do any of that if we don't have any standards or practices, best practices set in place. So that's a really big piece that we look at. Everyone across the city that we serve gets the same kind of experience. Transforming home care, as I said, that was the biggest fear for everybody, is around home care. How that's set out is very different. At the time when we started this, there's a lot more cluster kind of care happening now. But at the time when we started, it was very much task-oriented. You put out a service for a call, somebody picked it up, and they went to do the visit. This is a dedicated team that is trained by the UHN staff, and they work with us to create that. And they teach us, too, about, actually, that you don't need to do that in a hospital. We can do that very well in the community. So there's been a lot of going back and forth and learning with the team. But they're trained, they're dedicated. Because of the size of our organization, so this is where we fully recognize we have a lot of privilege and position in the system, the volumes that we have were able to help us prove this model out. So for those of you that are struggling and you're smaller, find a buddy who might be able to help you combine some of these volumes, because we had enough volume to then prove out a salaried model. and do this at scale so that we could help push and disrupt the system so that others could see this is actually possible if we really banded together. So that was a huge part of the transforming home care piece. Just checking time, how are we doing? Digital as an enabler, I'll just put a little pitch. One of my colleagues, Alexis here, is going to be doing a presentation on our integrated care digital strategy tomorrow morning. We'll talk a lot more about it there, but digital has to be the foundation. And when we talk about the future, we can't scale beyond what we have right now without embedding digital. And it is very difficult for organizations to go out and start doing their own procurements, creating their own systems, and doing the training around health digital literacy at the same time. So is there a way we can do this better as a team and come together on some shared systems and some shared practices? And the last one is integrated funding. This is what really gives us the flexibility. So combining what we have in acute care and in home and community care and having one person, well, one team oversee the bundle so that we can say, you know, Neem needs a scale, but she can't afford the scale, so why can't we give her the scale so she can share with us the weight so we can prevent an exacerbation moving forward? Stephen needs 2 visits, but Yinka only needs 1. Why can't we look at reviewing them to assess and reestablish and repersonalize? So that's really how we're using that one fund, and that is really pushing the way things are being funded moving forward. Okay, the next 2 are going to be really quick, so hang in there. So our 5-year journey, just to explain, time is really, really critical for us. So we are seeing this in 5-year increments. It took us 5 years to build the digital health record. It took us 5 years to start improving it. It's taken us 5 years to do this portion. So we started in thoracic surgery, Willing Coalition, lots of best practice there. We then all went through the pandemic collectively. We tried as much as possible to go through other pathways as we went through. So that's what we started. It wasn't perfect. Home care was not able to keep up at the time, but we continued and really worked through those pieces. And last year, we did 15 pathways. So when we talk about kind of going slow to go fast, it does take the relationships to build. You can go quickly once those pieces are done. But so this is where we're at in this acute return to home program. We will be enrolling about 4,000 patients annually. The satisfaction rate is about close to 92% from our patients. We are working on our care providers, but have heard lots of positive feedback there. And then finally, the last piece, these are very conservative, but every pathway that we go live in, the target is decreasing a 1-day length of stay and decreasing at least 5% readmissions and ED visits. I know you're going to kick me off. This will be in there. These are our tiers as we look at expanding. And then where we're headed. So a lot of scaled spread, a lot of it is going to be focused on advancing higher acuity care in the home, but we are also building out our pathways that start in the community so that we can prevent need for hospital moving forward.
Thank you, thank you. And unfortunately, we have so much to cram in because there's so much amazing work happening around the world that we do need to cut these things a little bit short. So the final presentation we have today is going to be from the Netherlands, from Päivi Rekman, who is from the National Institute for Public Health and the Environment, telling us about the Netherlands' experience of health system transformation.
Yes, there it is. Well, hello everyone. Thank you for the introduction. Thank you for all for being here. I hope you still have some energy for the last presentation. Because we heard lots of interesting things about integrated systems, important components, different pathways. And now I want to give you some interesting insights in the experiences with health system transformation from national, regional, and local perspective. Yeah, just some short background, not as complete as the Belgian one you just saw, but it's as we know, it's a very long, ongoing process to transform health systems. And here's a short timeline, but in the Netherlands, we first start to think about the substitution of care around 2013, and it developed to a more focus on the right care at the right place, which consisted of a program, and now finally we are at the step of a complete national agreement on integrated healthcare for the next few years, and a separate one really focusing on the health and well-being, more the prevention side of healthcare. Yeah, we all know to guarantee a health system that is accessible for all, has high standard quality of care, and doesn't stretch the limits of financial budgets, it's important to work together. And we found that it's very interesting and important to look at cross-sector collaboration initiatives or networks. So we started to look into that, and on the right for you, you see a figure with all new initiatives that came up in the Netherlands. And you actually see that it already started in around 2000, and the last couple of years more and more new initiatives came up. And today I will share with you the findings of experiences within those initiatives and the learning cycles we all have together. So what is the objective for our studies? It's really to reflect on the experience of the last couple of years, but also to look forward and see what kind of lessons learned we can use for the future, and what kind of challenges remain. For this qualitative study, we did 37 semi-structured interviews with a broad scale of stakeholders, you see on the right. So we spoke to representative of patient and client organizations, municipality, health insurance, program managers, different kind of health professionals and health providers. And after we spoke to them, we had a collective session, actually to exchange ideas and thoughts, but also for us to validate the lessons learned from the interviews and to discuss potential solutions together. Because as the others already said, you cannot do this alone, but to come up with these complex solutions, you have to be together with different perspectives. So some of the findings from our national perspective, it's that actually we see a positive trend in increasing collaboration and also shared enthusiasm. So it's not only one party who is really motivating the rest, but really from local, regional to national level, people are getting motivated to work together and to integrate care. But there are some concerns about the speed of change. And as we learned this week, transformation should be rapid, but actually if you see that in this timeline, it's something from the long term and it's a continuous journey. And some concerns about structural assurance, for example, connected to political changes, or so there are some focus points in that. Some experience from regional perspectives. We found that many participants said it's very confusing to have all these kinds of programs and rules and control structures and administration, so it's kind of confusing where to go and what to do in that. Also, they highlighted the importance of translation to local and regional context. And on the right, you see a quote for one of the participants that, for example, if organizations already had gone through earlier developments, as you saw in the picture, if they started earlier, they can continue and they can stay ahead and develop when more funding or new programs are implemented. But for regions who are not yet there and not undergoing that earlier development, it's difficult to stock up in, and they tend to stock up in official circle. Furthermore, so it's important that there is a remaining awareness on the different interests and needs. This may sound familiar, but it's really important for trust building and equality within different groups. And so another quote is that many participants said that you shouldn't be talking about, but with health and care professionals, which is a very important distinction. And then to the local perspective, connected with what is already there. There is a lot going on, and don't try to find the wheel for each person, but really connected to what's there. Don't ask the questions from a systems perspective, so also your research question, but really from a local point of view. Facilitate citizens to participate. It's something we tend to forget, but also, for example, financial facilitation to really participate on an equal level. And think in advance about who you involve and when you involve them. And expectation management about the future of healthcare and what it means for citizens themselves. This is linked to the visibility and also to balancing the triple aims. Then some lessons learned overall. Like I said, transformation is an ongoing, iterative and long-term process. And the meaning of which Professor Bengoa told us on Monday is emotion, and it means there's not one definition on transformation, there's not one outcome, it's a continuous motion. And for that, to achieve that, more connection and balance is needed between different perspective goals and levels of actions, and focus on equal input from all involved partners, especially the ones from healthcare professionals and patients and clients. And to come them, we argue that it's important to have an incremental approach, step by step, and have a collaborative learning. And, but then we still have some complexities in that thinking and those lessons learned, because what we find over the years is that there's a difficult balance and some kind of struggle between trust and control on national and regional level. You want to support change on regional level with grants, for example, but there's also some kind of accountability for that, but it's hard to find the right balance that everyone can be on board and has an equal say in the developments. And also what's important is that the different actors needs to be equally valued in decision making. So not only equally input, but also equally valued. And that means that you should not just invite them at the table, but really consider their input as equally valued. And that sometimes means you have contradictory ideas, but especially for policymakers, it's sometimes difficult, but we have to take that into account if we really want to move forward together. And last thing, which is important, is that connecting those systems and the world we are living in, you need not only time and financial resources to implement that and to do that, but also to experiment. So at the beginning, so that you also have the room and space to make some mistakes, but that you can learn together and eventually transform to a sustainable health system. So for us, the way forward, we tend to find multiple perspectives and put them in equal learning sessions, but also for us to go more to the regions, more to local practices, and really connect with the different worlds. And start and contribute to learning networks of research, policy, and action. So that's it for me. Thank you.
Thank you very much for that. And an excellent exhortation to take the leap there at the end. Unfortunately, I don't think we're going to have time for a panel discussion because it is the end of the day and I think we're all rather tired. I'm just going to very quickly reflect on some of the key themes that I think came through all 6 of the presentations that we had this afternoon. So I think we heard both frustration and optimism from Stephen, particularly in relation to the wheels of decision-making, which we all know, and I think that came through in each and every one of those presentations in terms of being patient, taking it slow, recognizing that sometimes slow gets there, whereas fast doesn't. What I heard from Belgium was also around that journey, taking that journey step by step and taking everybody with you. From Vicky, I was particularly interested to hear about the focus around measuring integration, because that so often gets lost. When we talk, sometimes integrated care becomes so big, it becomes an entire health system rather than just a focus around integration. And with Chris, I think sharing on the hidden work of that health and care systems do. And I sometimes think, well, I usually think, it's only hidden because we choose to ignore it. So it's not really hidden, it's work going on all of the time. It's just many decision makers choose to pretend it's not happening. I thought that Sharon was very brave to talk about castles, given that he's in the home of the Game of Thrones. So well done, Sharon, very brave. But really some really interesting learning, I think, from Canada, who are on a very accelerated journey around bringing together integrated care teams, particularly in the Ontario space. And then from Pavy at the end, I loved what you said about the trust control tension. And I think, again, that was a theme that pervaded in everybody's discussions around whole systems. As I say, we don't have time to pick up on the questions in the Q&A, but please do talk to the presenters at the end if you can catch them. I'm going to paraphrase, though, one of the questions. So Alan Katz asks about co-production. I'm actually going to slightly frame that a little bit differently and put a challenge back to the presenters. If you were to talk to any of the people receiving care in your place right now, would they say they've experienced transformation over the last 5 years? Would they feel their care has actually transformed? And how would you know? How would you be able to answer that question? What evidence do you have to help you answer that question? So, one to leave hanging in the air for the end of day 2, but I think it's something we will return to tomorrow. So, thank you all for joining us. It was fabulous to have all of you. Enjoy your evening this evening and see you all tomorrow morning.
Thank you.